Happy afternoon to one and all. I'm Dr. Maheshwari, Assistant Medical Director, GGIRHR. A very happy afternoon to all of you. I welcome each one of you today to the CME Meet Garbhagnan 2020, organized by GGIRHR and supported by Intas Pharmaceuticals. For those of you who do not know about GGIRHR, it stands. Happy afternoon to one and all. I'm Dr. Maheshwari, Assistant Medical Director, GGIRHR.
Ma'am, please unmute and ma'am, please unmute. Ma'am, please unmute. Hello.
Andrology, embryology, IUI, IVF, ultrasound, and a lot more. GGIRHR has an affiliation from IMA and RGHS University. Kindly note, the participant can ask their questions on the chat window. All the questions will be answered at the end of the session by the respective speakers. Any unanswered questions will be answered and shared with all the participants in an email. We will also be sharing the key takeaway messages of all the talks in the same email. To encourage the participant, we will be offering surprise prizes to the two best questions. So request all of you to ask the questions. Let me introduce the speakers of the event. The first speaker is Dr. Asha S. Vijay. She is the founder and medical director, Garbhagudi IVF Center. She is the Dean and Scientific Director, GGIRHR. She will be sharing her valuable knowledge on the latest update on poor responder. The second speaker is Dr. Sonal Panchal. Dr. Sonal Panchal is internationally renowned sonologist. She will be talking about ultrasound tips, tricks, and techniques for improving ART outcomes. She will be sharing her vast knowledge and deep knowledge and experience in the field of ultrasound in the ART. The third speaker is Dr. Sripada Jogarao. Dr. Jogarao is a postdoctoral research scholar in the healthcare law and ethics. He will be speaking about medical legal issues, a perspective in the current context of COVID 19 and its aftermath. He will be guiding the participants on the medical legal challenges that have cropped up due to COVID 19 pandemic and how to have a legally safe practice in these challenging times. Now I call upon Dr. Asha S. Vijay to start the first session of the day. Dr. Asha S. Vijay is a well-known fertility specialist, leading name in the field of fertility and reproductive medicine. She is a specialist in the field of infertility, obstetrics, gynecology, and obstetric sonology. Dr. Asha S. Vijay graduated medicine from the prestigious Bangalore Medical College and did her post-graduation in OBG from the same institute. She initially started a multi-specialty hospital called Sanidhi Specialty Center. Subsequently, she founded Garbhagudi IVF Center, a chain of IVF center in Bangalore, known for its extraordinary success rate, ethical treatment, and humane touch. She currently is the medical director of Garbhagudi IVF Center. She is also the founder, dean, and scientific director of GGIRHR, a premium reproductive health training organization. Dr. Asha S. Vijay is very passionate about conducting educational programs for gynecologists to help them improve their fertility outcomes. She is also an active participant and sponsor for multiple research papers in the field of infertility. Now I will invite Dr. Asha S. Vijay ma'am to start her session on the latest update on poor responders.
Thank you, doctor, for this nice introduction. Happy afternoon, all of you. So let us look into this latest updates about poor responders, which is a very vague term nowadays and a very confusing word too. Change of So as we all know, there's a goal for all ovarian stimulation, and that goal is multiple follicular recruitment, multiple egg collection, and hence multiple embryo creation, so that the lady who is infertile will have good cohort of embryos and will have good pregnancy rates and live birth rates. This goal is because of there are a lot of inefficiencies in embryo culture, in our in vitro labs, and embryo selection which happens, which is very different from the in vivo conditions, and also the implantation potential, which is very different from the natural cycles. These poor responders don't fit into this goal of ovarian stimulation by creating a good cohort of follicles, good cohort of eggs, and finally poor pregnancy rates and live birth rates. So let us look into this, why this happens. When I went into the literature, various use of terminologies were there, like bad, slow, inadequate, suboptimal, poor, low, too many and too confusing. Most often used is poor responders. So what is this hyporesponders and why is it gaining so much importance in nowadays? Let us look into this. Almost 15% of the normal ladies with normal hormone profiles, normogonadotrophic ladies who are supposed to be good prognosis fit into this hyporesponders category. They are well within 35 years. They have normal AFCs, normal AMH. When you see them and evaluate them, you feel that they'll give good cohort of follicles. They'll have very good pregnancy rates. And you would have counseled them in the same way looking at their ovarian reserve test, that is ORT, which will be normal. But they'll have very suboptimal response to the standard dose of FSH, which you would have started, say 150 to 225 IU per day, and they'll consume more than 2500 to 3000 IU of FSH, which can be in the previous stimulations or in the present index stimulation. It's almost found in 19.8 to 20% in the long agonist protocol and almost 15 to 17% in antagonistic protocol. So overall, if you take the incidence, there is a whooping 15.5% of the people who fit into this hyporesponders. How do we identify them? How do we give them pregnancies? What are the indices to measure their responses? That is our concern now. So when I looked for the various definitions, there were too many, too confusing. One said one previous cancelled IVF cycle. The other said who said retrieved must be less than 5. The other said age is the criteria more than 50. Some people took day 5 E2. Some people took day 8 E2. Many confusing definitions were in the past. So when there were, I checked on 57 RTCs, there were 41 definitions in them. So how will the doctors categorize their couples, their patients into one fixed category? So when I want to define these poor responders, we can define it as failure to respond adequately to the standard protocols and to recruit adequate follicles is called poor ovarian response. So what does this leads to? There are many increased cycle cancellation as you may be aware of in your daily practice. There will be very decreased oocyte yield. There will be very less embryo yield also. And as a result, there will be very decreased implantation rates, pregnancy rate, live birth rates, and there are many dropouts from the cycles because when we started the cycle, we told them you have a very good chance of pregnancy. But as the cycle continued, we were telling them a different version. So there are many dropouts, huge physical, emotional, mental, and financial burden on the couples. So you can see in this chart, they have compared the live birth rate with the oocyte number. It is so critical we get the good number of oocytes because low number of retrieved oocytes gives us a very low live birth rate. You can check here from 0 to 5 to 11 to 15, there is an increase from 17 to 42% of the live birth rate. So high number of retrieved oocytes definitely at a risk of OHSs, but we have to balance the two extremes of these cases into moderation. See, in this prediction of live birth rate according to the number of retrieved oocyte, I want to make one point clear here. Just getting one oocyte more in a poor responder, whatever the age group, significantly increases her live birth rate. Just check here, 35 to 37 years, just getting one oocyte extra has increased her live birth rate from 13 to 18%. Isn't it significant? So we have to aim at a significant number of oocytes. Whatever measures we have to take, tailor make the stimulation protocol or give them pre-stimulation adjuvants, has to be done very meticulously. Otherwise, they'll end up in the same scenario which they were when they came to you. Even the euploid blast and the correlation of the oocytes, you can see here, each supplementary meta to oocyte increases the chances of getting one euploid blast by 11 to 20%. How significant it is, one oocyte. So what could be the possible mechanisms for these poor responders or hyporesponders? I want to stress this point a lot. Poor ovarian response is the first sign of ovarian aging because the ladies are marching towards early ovarian failure or early menopause, which is not yet evident in our ovarian reserve tests and in the AFCs or the AMH, which we do regularly. So only when you do an index case, when they respond very poorly to your response, we know that they are coming under this poor ovarian response category, and that could be the first sign of ovarian aging. Because if you don't have this in mind, they'll go hilter and shelter to all the centers with all other specialities, go with all other homeopathy, allopathy, Ayurvedic, where's the reserves, come back with complete failure. So we should have this in mind. What are the possible mechanisms? There are decreased numbers of FSH receptors on the granulosa cells, which will fit into this hyporesponse, and defective signal transduction after FSH receptor binding. There is an inappropriate local vascular network. Therefore, the transport of the gonadotrophins is not happening properly in them for the dosages which we give. There are presence of autoantibodies against the granulosa cells in these couples. And also abnormality in the insulin-like growth factor 1 and 2 levels have been seen in them, which is very significant. Vascular endothelial growth factor receptor 1, there is an excess seen in these patients. There is diminished circulating gonadotrophin surge attenuating factor bioactivity. This is gaining lot of importance nowadays, GNSAF. And lastly, and the most important, there is a huge genetic background to these people. There are polymorphism, genetic mutations of the FSHR gene and LHR gene. And there is a lot of researches going on this field, which will be published shortly. Environmental contaminants are getting a hold on this, and lot of oxidative stress, build of ROS inside the follicular fluid. Everything could be a possible mechanisms to these subset of ladies with a hyporesponse. So this concept of hypo or suboptimal response, a study was done, a retrospective study in 1099 patients, watching out for the critical role of number of oocytes. The cumulative live birth rate, both in fresh and frozen transfers, how it increases with the number of oocytes, just see there. With 1, 2, 3 oocytes, the cumulative live birth rate is only 22%, the orange squares. But when it becomes 10 to 15 oocytes, it has almost doubled to 51%. So there is a critical role of number of oocytes which we have to keep in mind. Because there was so much confusion in categorizing this subset of people, Ishre and Bologna came to a consensus on poor response, and they gave us few criteria to define these subset of people. They said that at least 2 criteria should be there: advanced maternal age, a previous POR, that is less than 3 oocytes retrieved, or an abnormal ORT. I'll be using this word often, ORT. That's called ovarian reserve test, where AFC is less than 5 to 7, AMH is 0.5 to 1.1. Yes, everybody was happy, at least something has come up. That was in 2011. But it had lot of limitations. There was lot of heterogeneity in the population. Oocyte quality was not reflected upon. There was no definition at all for suboptimal and hyporesponders. And ORT cannot predict this hyporesponders as well. And there was no option for treatment, whatever the treatment protocols has to be taken, how the patient should be counseled. Nothing was mentioned in this consensus. So there are lots of limitations. Then in 2016, the Poseidon group came into picture, where they categorized these heterogeneous subgroups into 4 very neatly made groups: that age less than 35 normal ORT, group 2 more than 35 years normal ORT, group 3 less than 35 poor ORT, and the group 4 with the least prognosis more than 35 with a poor ORT. Each of them are very different. They behave very differently. Their protocols are very different. We have to categorize our couples according to this Poseidon grouping. So new categorization of patients based on an impaired response to controlled ovarian stimulation was done. Both qualitative and quantitative kept into consideration. They defined this endpoint as, I want to reiterate this, they defined this endpoint of this COS as the ability to generate the number of oocytes which can produce at least 1 euploid embryo in this subset of patients. So we have to have a good cohort of oocytes which can give at least 1 euploid embryo. It also took into consideration ovarian sensitivity gonadotropins, and more clarity came in implementing COS in this impaired response people. So there were subgroups like this: less than 35, AMH more than 1.2, AFC more than 5, age was less than 35 and more than 35. 3 and 4 had very poor ORTs, AMH less than 1.2 and AFC less than 5. And according to the age, they were grouped into 3 and 4. So what is this Poseidon group 1A? I showed you here, that is group 1A is less than 4 oocytes. 1B is 4 to 9 oocytes in their previous cycle if they have all records of it. So what do you do with the Poseidon 1 group 1A? They are young, normal ORT, but they are poor responders. So we have to do a reassessment of ovarian reserve testing. We have to check for genetic polymorphism if it is feasible in the center and in the place where you're working. Changing simulation protocol strategy. The FSH starting dose should be tailored into a higher thing, and adding RLH was the beginning of stimulation with 150 international unit per day. In group 1B, you have to tailor the RFSH dose. Genetic polymorphism should be checked, and also RLH should be added with 150 IU per day. See, adding RLH can be done when you see a stalling of follicles or there is no growth of the follicles on day 7 and day 8. Though you are giving enough RFSH like 200, 225 IU, 300 IU, then you have to take this into mind that they might be the hyporesponders who are in requirement of RLH, and add 150 IU. There are many RCTs comparing 75 IU with 150 IU, and there is a lot of concrete evidence with 150 than 75 and with RLH than HMG. So you have to keep this in mind when you are treating these couples. Gonadotropin polymorphisms, you will see a young age group, normal clinical features, normal ORTs, but the FSH conception was more than 3000 IU in the previous stimulation. Keep that in mind. And there is a lot of follicular growth stagnation in the mid follicular phase. They are not coming into that normal category of 1 to 2 mm per day follicular growth, and the E2 is not increasing by 50% every day. So you have to be very conscious of all this when you are treating this group of population, and they constitute around 13 to 15% in the general population. So they'll be coming in and out into your clinic every day. So what do you do with the group 2? You have to change the stimulation protocol strategy, add RLH from the beginning, and aneuploidy screening is a must because they are all more than 35 years. You have to counsel the group 2B because they have to have multiple stimulations. You might have heard of the word accuvate, where you accumulate the oocytes and you vitrify the embryos. That has to be counseled them from the initial stages because they don't get a good cohort of follicles and good size of oocytes. What are this Poseidon group 3? Young diminished ORT. We have to focus on follicular synchronization here. Because of follicular asynchrony, we don't get much oocytes in these people. We have to do an optimal FSH stimulation with recombinant than urinary preparation, which really gives good response in these people. Add RLH instead of HMG from the first day of stimulation. Counsel them for diostim, that is dual stimulation, follicular phase and luteal phase stimulation, and also counsel them for oocyte accumulation, which is very, very vital for them. Group 4, minimum burden of stimulation should be given because there is no increased advantage more than 300 IU of RFSH. I'll show you in the further slides. Counseling should be done. Counsel them for ovum donation also. What could be the risk factors for these POR groups? Advanced age is the most relevant risk factor here. Pelvic infections, endometriomas, overzealous drilling, previous chemotherapies, radiotherapies, smoking in ladies, obesity, when there is a family history of early menopause, and there are many, many unknown factors too. So what did this Poseidon define us? They wanted to test the ovarian sensitivity to our administered FSH. How do you do that? We cannot be caught off guard when you do a OPU and you get a very few oocytes. You should have some measures of metrics that you have to know that they're coming under hyporesponders. So they defined this follicular output rate, FORT. Keep this in mind always when you are doing a proper stimulation. FORT should be calculated. See, this lady, 29 years, AFC 15, she has only given 5 pre-ovulatory follicles. Can you see that? AMH is 2.9. You have done a best stimulation. And her FORT comes to 33%. That is pre-ovulatory follicles by AFC into 100. Whereas this lady, AMH low, AFC low, with only 5 AFC, has given us 5 pre-ovulatory follicles of 17 mm. So our FORT is 100%. So how do you grade these two people now? Depending on the FORT. So concept of ovarian sensitivity to FSH was measured by follicular output rate. See, when you have started a stimulation and there are only few follicles developing, you have come to stimulation day 5 and 8, you are seeing only 5 follicles developing. You have to have some strategy to save this cycle. Otherwise, the cycle will be cancelled. So what is the intervention needed here because of the poor response? Either you can increase the RFSH or you can add the RLH, or you can counsel them time to time that this is happening and they have to go for one more cycle. You have to keep them updated. Can you see this? S5, S8, finally only 5 follicles have come and she fits into your poor responders. So how do you calculate the FORT? You have to know this quantitative and qualitative marker of ovarian responsiveness. You calculate all the pre-ovulatory follicles of 16 to 22 mm on HCG day and divide by small antral follicles 3 to 8 mm on baseline and into 100 will give you the proper ratio. So it significantly correlates with FSH levels, AMH levels, and your duration of COS and good embryos too. It's divided into 3 groups. Please note, low FORT is less than 33 percentile, average FORT is 33 to 67 percentile, and high FORT is more than 67 percentile. Just for a comparison, I put a normal responder. See, the AFC is 15 when you began your stimulation, and good number of follicles have come up, and the FORT is around 60%. But in a hyporesponder, though the AFC is 15, only 3 follicles have come and her fort has become 20 to 30%. So she comes it in the very low fort group. So what does an hyporesponse mean? Not all of the follicles are recruited because of the insensitivity, though AMH and AFC is normal, and only 4 to 9 or less than 4 follicles will be giving us good oocytes. It reflects an hyposensitivity of the granulosa cells to our stimulation. They gave us an even more better index to measure our COS efficiency called FOI, that is follicle to oocyte index. This is even more better than the FORT, where you divide the oocyte number by the antral follicle count into 100. There are 4 categories here. Normal FOI is more than 50%. Low FOI is less than 50%. There are 4 categories of people here who have recruited good number of. They have given us a good cohort of oocytes, and you can calculate the follicle to oocyte index and counsel them accordingly. So what is the pathogenesis of low FOI? It could be a low gonadotrophin starting dose. So it's very, very important to know. You have to have a proper protocol for this lady, tailor-made. It cannot be blanketed. So you should know what is the starting gonadotrophin starting dose for this lady. If it is low, low FOI will result. Genetic or environmental factors, as I discussed previously, I want to stress upon this asynchronous follicular development, which will give us very bad fort and FOI. So we have to have a pre-stimulation strategies for these people so that there is a good cohort of follicles which come up and give us a good follicle to oocyte index. And I want to stress here the doctor's skill sets has to be very nice, very strong, because if you're not good at oocyte pickup, you may end up getting very less number of oocytes, though your stimulation was good, though your trigger was best, but you could not pick up enough oocyte because of the bad skill set. So there are many definitions for FSH hyposensitivity, but as I told you, normal ovulatory, normogonadotropic young patients with no follicle of 10 mm on day 8 of stimulation, or stagnation between day 7 and day 10 by D Placido summarizes everything. So there are almost 15% of patients undergoing COS who come into this picture. They show hyposensitivity to granulosa cells, high FSH dose consumption, low FORT, low FOI, and there is follicle growth stagnation, and the cycle can be rescued with LH activity addition. Most of the cycles are recruited, E2 comes up, oocyte competence comes up, and embryo quality comes up. So what is the clinical interpretation? You have to give adequate FSH stimulation. There will be an unexpected poor responder, stagnation of growth, or a suboptimal responder. So LH rescue comes to the rescue of this cycle. So there are different subgroup of patients. We cannot compare these two subsets and have a same cycle or same protocol or same strategies for both. So ORTs, they predict poor responders where there is more than 40, FSH more than 10 to 15, AFC less than 5 to 7, AMH 0.5 to 1.1, inhibin B less than 45. When you measure the volume of the ovary, it will be 3 centimeter or less. And when you check their testosterons, they'll have very low levels. And other dynamic tests, which is not in vogue nowadays, like clomiphene citrate challenge test, GSF, gonadotrophin stimulation test, or effort, which are not done nowadays. So this age-related quantitative and qualitative dotted line shows us how the ovarian follicular pool drastically declines over age, and we have to have this in mind when we are stimulating the ladies. So there are many sensitivity and specificity for FSH, AMH and AFC, but AMH and AFC together gives us very good sensitivity and specificity along with the lady's age, which we have to combine. So when they increase the FSH dose from 300 to 450 to 600, not much of a difference was seen with total FOI, mature oocytes or embryo transferred rate or the live birth rate. So I just want to tell you that increasing the RFH starting dose over 300 IU is a useless endeavor. because the ovaries are already dead and tired. You cannot drive the dead horse anymore. So there's a lot of talk going on in the role of LH during folliculogenesis because it really increases the FSH receptors on the granulosa cell. It increases the responsiveness of the gonadotrophins on the ovaries, and it acts synergistically with the IGF-1. There is huge recruitability of preantral and antral follicles. Many roles of this, and finally increases the FORT and FOIL, and it optimizes the steroidogenesis. So you all are aware of this LH physiology in reproductive cycles, how in the early follicular cycles it improves the steroidogenesis, and in the late follicular phase it upregulates the FSHR expression, sustains very good follicular growth. So below a minimum threshold level of LH, follicular development will plateau. Maximum steroidogenic response can be elicited only when 1% of the follicular LH receptors are occupied. So there is a synergistic action between FSH and LH. So you cannot stimulate the whole of the cycle with only RFSH, increasing the dosages and changing the pattern of the protocols. You have to add LH to get a good response in these hyporesponders, because LH through androgen production improves the granulosa sensitivity to FSH, and increase in the number of FSH receptors happens, and you have to supplement with LH when your FORT calculation is low. So 150 IU of RLH was more effective than 75 IU of RLH in these hyporesponders. So when you are increasing the RFSH dose alone or in supplementing LH, there was great improvement in the oocytes, M2 oocytes, implantation rates and pregnancy rate. And also they found in these RCTs that when the LH activity is substituted by HMG, the results are not so pronounced like when you add recombinant LH. So why LH in the poor ovarian responders and old age? Because they have impaired oocyte quality, there's very decreased fertilization rate, reduced embryo quality, and also because of increased miscarriage rates. Reduced ovarian paracrine activity, androgen secretory capacity, and LH receptors are very much bioactivity is reduced. So you have to have LH in such old age people and in such poor responders. So what is the rationale? It has an anti-apoptotic effect on the granulosa cells, and it increases the FSH receptor responsiveness, and it has a synergistic action with insulin-like growth factors and upregulates the growth factors. So LH supplementation will really aid you in having a very good FORT and very good FOIL. So there are so many protocols before the actual stimulation happens in the form of androgen supplementation. There are many RCTs, meta-analysis proving that they are very effective, very efficient, because DHEA, when you start with 75 milligram per day, 6 to 8 weeks before stimulation, it will have a lot of effect on your actual stimulation in reducing the RFSH dose and giving you a good follicular cohort and good follicular oocyte cohort. So how you can give this? 75 mg per day around 90 days before the actual stimulation, or you can give them with testosterone gel 5.5 to 12.5 milligram per day, either in a short-term course from day 15 of the preceding cycle, or you can give it 2 months before. So there are many studies telling us that transdermal testosterone poor responders will actually give us very good outcomes in live birth rate and reduces the dosage of FSH required. In all these studies, they have studied about DHEA and human growth hormone, which can have a very big impact on hyporesponders. DHEA 75 milligram per day, I told you 90 days before. Human growth hormone, there are many protocols. Many studies have shown that it is 4 to 8 IU starting on day 1 of stimulation, continuing up to the HCG day. Now there is a recent study which shows that you can start from the day 21 of the preceding cycle when you are going for the long agonist protocol with a very small dose of 0.5 international unit 2. I'll share all those studies with you later. So you are seeing here the role of androgen, synergism between the FSH and androgen, how the recruitment happens, selection happens, and how it increases the FSH receptors on the granulosa cells. Many questions come up with the OCP pre-treatment for poor responders, thinking that there will be long suppression in these people. They may not respond to gonadotrophins, but there are many studies telling that 12 to 15 days cycles of OCP pre-treatment will give a very good enhancement of the estrogen receptor sensitization, gives a good pituitary suppression. So it gives a very good synchrony of follicle, good cohort of follicles. There won't be varied number of sizes of follicles, and it decreases the ovarian cyst formation. And as I told you, the homogeneity of the cohort happens in a very nice way when you give just 12 to 14 days, give 4 to 5 days of washout period, and then start your stimulation. There are many pre-stimulation protocols happening in the luteal phase of the previous cycle. Because there is follicular size discrepancy, early recruitment happens in the poor responders and hyper responders because there is an increase in the FSH. This is commonly seen in pure and with short cycles, leads to uncoordinated follicular growth, just playing havoc on the stimulated cycle. So what are the things we can do in the luteal phase of the previous cycle? You can give a estradiol priming, estrogen priming of 4 mg, 2 mg BD from day 20 to day 2, reduces the size and improves the homogeneity of the cohort. It increases the number of follicles reaching maturation, and the synchronicity comes on very well. Many people use GnRH Antac 3 mg and day 25. If you don't have 3 mg, you can just give 0.25 mg itself for 3 days. It reduces the size disparity of the early antral follicles. AACEP protocol, where GnRH agonist is continued from day 21 of previous cycle, and you stop on day 1 and convert to the Antac cycle, as well as E2 priming in the previous cycle, gives very good results in terms of good follicular cohort, good oocyte yield, good embryo yield, and improving the live birth rates. There is many studies going on with progesterone primed ovarian stimulation, where MPA or dihydrogesterone has been used in terms of agonist or antagonist, gives very good cycle outcomes. Fisher protocols, where norethistron acetate was used from day 15 to day 20, and this gave us a good synchrony of follicles. There was a worldwide survey in 45 countries and 196 centers where 1 lakh more cycles were assessed, asking them which is their preferred cycle. Most of them went for 53% of them went for GnRH antagonist cycle because of the ease of the cycle, less number of injections, and when they compared it with the agonist cycle, the M2 oocytes, the cohort which they got, the embryo quality, the implantation potential, live birth rates, everything was similar with all the other protocols. So majority opted for an antagonist protocol. But when you go for an antagonist protocol, you should have the previous luteal phase, proper pre-stimulation strategies in place to get a good synchrony. Otherwise, we will land in soup. So there are many modifications in the long protocol. Many icons of the IVF industry promote this long agonist protocol, saying that this is the best approach for the hyporesponders because of the good cohort of follicles and because of a good synchrony, and we get a very good follicle to oocyte input. So they continued the GnRHA throughout the stimulation, but at a very low dose, not like the normoresponders. Stop protocols, you can stop the agonist when you start the gonadotrophins or continue at a very minimal dosages after the stimulation. There are mini dose protocols where you do 0.1 mg from day 21. Usually we start with 0.5 normoresponders. Here we do it as 0.1 and make it as 0.05 when you start the gonadotrophin. This works well with poor responders. And because you have done that, you get a reduced gonadotropin requirement. You get a high E2 on day 8, more than 180, more mature and good quality embryos also in many of the meta-analysis. Flare or short protocol is not done because it has a disadvantage. It increases the P4 and testosterone levels, and it doesn't give a good yield of oocytes and embryos. Microdose flare protocol is also in vogue now. 40 microgram lupride acetate BD is started from day 3 to till the HCG trigger. Antagonistic protocol, you are all aware, because of there is no initial pituitary suppression in the early follicular phase, which is a critical period for a good follicular recruitment. It prevents premature LH surge very efficiently, and there is a short treatment period, and there is a reduced risk of menopausal side effects, cost effective, very minimal number of injections used. So all these are advantages with the antagonist. As I told you, antagonist was compared with all other agonist protocol, microflare, mini dose, everything. There was no clear advantage, number of oocytes, mature oocytes, clinical pregnancy, ongoing pregnancy, live birth rate, everything was comparative. So what is this dual stimulation which is happening nowadays, which is most talked of in these poor responders? This concept has come into picture because we have 2 to 3 waves of follicular recruitment in one cycle. As believed, it is not only one wave of follicular recruitment. Encashing this, people have started doing follicular phase stimulation and luteal phase stimulation in these poor responders so that we get a good oocyte yield and good embryo which can be vitrified. So HMG with GnRHA agonist trigger is done in the follicular phase stimulation, and then pickup is done given 3 to 4 days of gap, and then again one luteal phase stimulation is done. See the comparative number of oocytes which is got in the follicular phase and the luteal phase. And in this you can see it's a prospective study. M2 oocytes, COCs, cumulus oocyte complexes, fertilization rates, biopsy blast and euploid blast among the follicular phase and luteal phase, it's almost similar. Similar euploid blast formation rate was also seen in both the phases of stimulation. There is a term called Shanghai protocol or double protocol. It is also 2 OPUs in a single menstrual cycle. RCTs in poor responders. More studies are required to evaluate this. This is the Shanghai protocol. Clomiphene citrate is started, letrozole, ibuprofen and MPA along with HMG. The trigger is done with agonist, and again gap is given. HMG 225 is started. Again one more OPU is done. For the luteal phase stimulation, you should have at least 2 to 3 8 mm follicles to stimulate again. So luteal phase ovarian stimulation following oocyte retrieval, is it helpful for poor responders? The conclusion was it has a very good quality embryos and good mature oocyte yield. So this can be helpful in lot of poor responders. There are many interventions to enhance IVF outcomes. We have to start with a high dose gonadotropin. We have to have a modifications of the long protocol or antagonist protocol. Natural cycle IVF is not so much promoted nowadays because of its own disadvantages. Day 2 embryo transfers were done instead of day 3. But nowadays, recent studies are again telling day 5 embryo transfers are better because one euploid blast will give us 50 to 60% implantation potential across all age groups. And the way Poseidon group measures the effectiveness of our stimulation is number of oocytes got to get one euploid blast. So day 5 transfers are the most beneficial for this subgroup of ladies. There are many adjuvant therapies, as I told you, pyridostigmine, growth hormones, LH adding, androgens, DHEA, transdermal testosterone, OCPs, E2 pre-treatment, etc. etc. This is a very important slide. I want all of you to concentrate here because ovulation triggering agent for POR is the most crucial, which will really save us that cycle, give us a good oocyte yield, and will save us from having a very good embryo cohort also. Individualization of the COS protocol called ICOS, individualized COS, and individualizing of the ovulation trigger strategy is very crucial for this subset of ladies. Many people advocate HCG trigger. Many go for GnRHA trigger if there is dual stimulations. But recent evidence shows that dual trigger, when both are administered simultaneously, gives us a lot number of M2 oocytes than HCG trigger alone or GnRHA trigger alone. Then what is this double trigger? They have done lot of studies with this double trigger. That is, you give HCG at 40 hours before OPU and 34 hours before GnRHA, and you combine this double trigger with the dual trigger. They said that some people will require a longer time for the detachment of the oocyte on the expansion of the cumulus oocyte complex. So double trigger has given them more good results than dual or HCG alone, GnRHA alone. Egg retrieval in POR, you have to be very careful because there are very few follicles. The access might be difficult. You should be very good in your pickups, very fast. The pressure should be perfectly placed. The staffs giving you support should be very good, so that if you are anticipating 4 to 5 oocytes only, you should be able to retrieve all of them with good, very good skill sets. Embryo transfers in POR, many studies are growing, advocating fresh versus frozen. Also, there was a lot of studies saying that cleavage stage embryos are better than day 3. But again, the things are favoring day 5 transfers nowadays because the implantation potential is huge with blast. Single embryo transfers with double embryo transfers. When you transfer 2 embryos in such ladies, the pregnancy rates were very high, but the risk of multiple pregnancy in this group will become higher. Sequential transfers may not be possible because the oocyte yield and the embryo yield of these ladies are already compromised. So as I have to summarize, this group 1 people should be having a starting dose of RFSH more and add 150 IU of RLH to the 300 IU RFSH, so that you get a very good cohort of follicles and you get good subset oocyte yield. Strategy in patient with hypos response group 2. Similarly, you have to add RLH. Also, you can consider dual stimulations. Same slide, Poseidon group 1 and 2 management strategies I have put here, what I have spoken already. Best practices in Poseidon group 1 and 2, just open this page. It's available on Google, poseidon.com. Everything is summarized here beautifully. What is a pre-stimulation? What is a stimulation? What is a trigger? What is a retrieval rate? How FOI and FORT can help you? Everything is there in this group 1 and 2 best practices. 3 and 4, they are poor reserves because their AFCs and AMH is already compromised. They have a very high FORT. So you have to tell them about the chances of them getting a very poor embryos, very poor oocyte yield. Talk to them about dual stimulation and also the role of PGT. Best practices is Poseidon group 3 and 4. They talk about the adjuvant treatment here, growth hormone treatment. I want to stress CoQ10, coenzyme Q10 here, 600 mg per day in such population for 2 to 3 months before the actual stimulation will really give us very good results. And they have compared the long agonist protocol, antagonist protocol with the dual stim. All had comparative outcomes. When you are doing a long protocol, HCG trigger is the only option. When it is antagonistic protocol, you have option of both. But in the dual stim, GnRHA trigger is the only option in the follicular phase. There's a very beautiful thing happening with this Poseidon group now. This is the validation of ART calculator. This is a mathematical model where you feed in the lady's age, the sperm source, and other parameters, and it will give you how many oocytes are required for this couple to get one euploid blast for transfer using IVF and ICSI. So it's you have to just feed in these details, and before the actual oocyte retrieval, it will show you how much oocytes are required for one euploid blast. So in this lady's parameters, it is showing that she requires at least 11 mature oocytes to get one euploid blast for transfer, which can give her 50 to 60% pregnancy rate. After the actual stimulation, where they got only 7 oocytes, they fed the parameters again, and it is telling that you have 54.72% of getting chances of getting one euploid blast. Keeping this in picture and with the couple in front of you, you can counsel them what is the fault you are expecting, what is the FOI which happened, what is the ART calculator which is telling. Should they go for a luteal phase stimulation again in the same cycle? If you are clear with them with all steps, there will be no dropouts and there will be lot of reduction in the mental agony which the ladies happening in hurry throughout the cycle. So I want to just present one case presentation. It's a very interesting case where Dr. Ramya names have been changed. She is a postgraduate in a cancer institute. She came with married life of 5 years. All her parameters were reduced. AFC reduced, AMH reduced, FSH reduced, Poseidon group 3. And IVF cycle we started. We started on Antac cycle with Gonalf 150 and Menopause 75. We noted lot of stalling of follicles and the E2 was not up to raise. So HCG 500 was given as a trigger. See, her fourth calculation is coming up to, because AFC was 6, only 4 were recruited, 66. 5 was even less, 33. She got only 2 embryos frozen. Then we sat with the couple and we told her we have to do some other pre-stimulation protocols for her, advised her accumulation of oocytes and vitrification of embryos, started androgel 8 weeks before. Our AFCs increased from 3 plus 3 to 7 plus 7. See the huge difference in the AFCs because of androgens. Started the same stimulation but increased the dose to 150 and 150, RFSH and RLH. Agonist trigger was given because E2 was more than 3000. She got very good FOI. 11 M2s, 10 embryos frozen. FET was done sequential, twin gestation. I think she has delivered now. Her FOT was 64, FOI was 64. A very good score. This case, Mrs. Usha, her names have been changed. She had very good AFC, very good FSH, very good AMH. Her age was 27. Antag was started, RFSH. Right ovary showed no response. Left ovary showed lot of stalling of follicles also. We got only, how many oocytes were? FOI was only 25. We got only 4 oocytes. Fresh transfer was done because the embryo quality was not good. Pregnancy was negative. Though she believed belonged to Fosidan 1A, her response was very, very poor. She was not at all open for donor oocyte. She was counseled for a long agonist cycle. So day 21, 0.25 mg was started and it was converted, 0.5 was started, converted to 0.25. Her AFCs became 6 plus 6 and Gonalef 225 RFSH was started and we added growth hormone to her 4 units from day 3. Menopur was also added and we got 13 oocytes. Our FOI was 100. ICSI PISA done. 10 very good embryos were got. FET done. Twin gestation. CR, individualization of the protocols is very, very important. Triggering is very important. Pre-stimulation, adjuvant treatment is very important. Categorizing the ladies into the different subgroups and tailor making their protocols is very, very essential. So what is my key messages? Every clinician should have this in mind that there are a subset of population called hyporesponders, which we have to recognize and we have to categorize them accordingly and individualize their stimulation protocols. Normal ORT does not mean normal responders. ORT is ovarian reserve test. There should be proper pre-stimulation protocols, which has a huge impact. As you saw in those 2 cases, I have many, many cases. I can discuss it in the later webinars. Follicular number and oocyte number is very, very crucial for successful IVF. FORT and FOI, please keep this in mind. Calculate for every hyporesponder or normal responder until it becomes a normal thing for you. Choosing of protocols is very, very important for successful pregnancy rates. So thus ends my speech. Once you stop learning, we start dying. So said the great maestro Albert Einstein. And growth is our willingness to give up what we are to become who you can be. Without give up, there is no go up. So we have to keep learning new things and we have to give up the old knowledge to learn the new things. Thank you so much, friends. Yeah. Stage is open for questions. Yeah, MCQs. There are few MCQs which I have designed. So you can answer them. So I'll know how I was. Are you seeing the questions? You can answer from your screen itself. And from your mobiles too, I think, isn't it? Fourth means 4 choices are there. Can I view it? follicular output rate, follicular recruitment time, fast oocyte recovery rate, none of the above. Start answering, please. I'll answer them after you people start giving your results. After 5 minutes of it, I'll answer. Dr. Sonal Panchal madam is with us. Happy morning, madam.
Morning. Thank you very much.
So nice to see you.
Same here.
Can I get the survey? Questions, sorry. So follicular output rate 63.64, recruitment rate 9. Fast oocyte recovery rate, none of the above. Where did you get this new definition, fast oocyte recovery? I had used my intelligence to put it. It's a follicular output rate, 60% of you are right.
We don't see the screen. This is the first question, this is the answer.
But I'm not able to see that. So FORT means follicular output rate is the right answer. Almost 65% of you are right. FOI means 91% people are telling follicle to oocyte index, 28%, follicle of oocyte index. Good take home. Normal FOI is less than 30%, more than 30%, less than 50, more than 50. Very good. 69% of the people are telling it's more than 50. You take few cases of yours and calculate the FOI and find out where they belong to. Suboptimal responders means retrieval of less than 4 oocytes, retrieval of 4 to 9 oocytes, E2 less than 500, all of the above, 26.6. The actual answer is retrieval of 4 to 9 oocytes. Less than 4 becomes poor responders, not suboptimal. Posidone group 3 has all of the below characteristics except they have not done. No?
No answers. You can state the right answer.
They have not taken it. So group 3 is less than 35 is correct, less than 1.2 is right, AFC less than 5 is correct. So the only thing which doesn't belong here is FSH less than 7. Is it so difficult? Okay. Thank you so much. Madam is waiting. Right? The Sonal Panchal madam. Video.
No.
Thank you, Dr. Asha S. Vijayaman, for sharing such a valuable information on poor responders. Thank you, Dr. Asha ma'am, for sharing such a valuable information on poor responders. The highlights are poor response. Poor ovarian response is the first sign of ovarian aging. You have explained in detail about Poseidon criteria, FORT, that is follicle output rate, FOI, follicle to oocyte index, how to manage hyporesponders by increasing the RFSH and recombinant LH. You have nicely explained the luteal phase modification, different protocols in the treatment of poor ovarian response of patients. Thank you, ma'am. Now, I would like to invite our second speaker, Dr. Sonal Panchal ma'am. It's our privilege to introduce Dr. Sonal Panchal ma'am to all of you. Dr. Sonal Panchal is a well-known personality in the field of ultrasonography. She completed her MBBS and MD radiology and imaging from Ahmedabad. She has achieved great heights in the field of ultrasound in the infertility, 3D, 4D ultrasound, and she is recognized as a pioneer in the application of Dopplers, 3D and 4D in infertility. She is a popular teacher and has delivered more than 500 lectures at various national and international platforms. Dr. Sonal ma'am has also presented various acclaimed research papers in her career. Many of these are highly appreciated and have inspired further studies by our other experts. Dr. Sonal ma'am has also contributed to various books on the usage of ultrasound in male and female infertility, fetal echocardiography, usage of 3D and 4D ultrasound in obstetrics and gynec practice. She has also contributed extensively to various national and international journals and magazines. Now I invite Dr. Sonal ma'am to talk about ultrasound tips, tricks, and techniques for improving ART outcomes. Ma'am, your session starts now.
Thank you very much for those very kind words. And thank you very much to Dr. Asha for this wonderful webinar. And thank you for making me a part of the same. So what I'm going to...
Dr. Sonal ma'am,
Yeah.
you can start the session, ma'am.
Am I not audible?
Ma'am, we are not able to hear you, ma'am. It's mute. Can you just unmute it?
It's unmuted. It is unmuted. If it
Yeah,
is...
we can hear you, ma'am. We can hear
Ma'am,
you.
unmute, ma'am.
I'm unmuted.
Yeah.
Can you hear me?
Yeah, we can hear you, ma'am.
Perfect. So thank you very much to Dr. Asha and the GarbhagudiIVF Center. And congratulations for this wonderful webinar. To start with, I'm going to talk today on ultrasound tips, tricks, and techniques.
Ma'am, please go ahead, ma'am.
Am I audible? Hello?
You're audible to me, ma'am.
Please go. Please go.
So please go ahead.
Okay. So, tips, tricks, and techniques to improve the ART outcome. After that wonderful lecture on the stimulation protocols for poor response, I think my job is a little more easier because I'm going to start with the deciding stimulation protocols. But before that, it is essential that we know everything about doing that ultrasound, the tips, tricks, and the techniques. Because ultrasound is the modality of choice for monitoring management of assisted reproductive technologies, and therefore it's become essential to master this technology. Transvaginal ultrasound is the method of choice, and to get the expected results, we have to start from knowing the correct technique of doing a transvaginal scan. We have to adjust our scanners in a correct way so that we get very good images on which we can do a proper interpretation. The ultrasound interpretation should be also standardized, and we have to correlate the ultrasound findings with the hormonal changes occurring during the cycle, and that is the key to the high success in ART cycles. To start with, when you introduce the probe, it is essential that you start examining or you start assessing the image right from the time your probe is still at the introitus, and that is when you are seeing the vaginal walls, you are seeing the urethra, the bladder, you are seeing the rectum. So you're seeing the posterior interface and the anterior interface. So the interface between the vagina and the rectum and the vagina and the urethra, which are the commonest sites for deep endometriosis. And we know that if there's endometriosis, the results are definitely going to be affected. So you have to start observing from there. I'm sorry, you have to start observing from there, and you will always check with an in and out movement the free sliding of this tissue interfaces, as you can see there. And as you introduce your probe, you're seeing the cervix there and you're seeing the uterus. Now, if this is achieved, that means the uterus is right in the midline, and you have most likely excluded the possibilities of congenital uterine abnormalities or the Mullerian abnormalities. Once you have reached the uterus, the first thing you'll do is you take a longitudinal sweep across the uterus, as you're seeing there, and you will rule out any possibilities of endometrial affection by pathologies of the uterus. You do the same with rotation of the probe 90-degree anti-clockwise. So in a transverse axis, you're going to do the complete survey, as you can see there, and that finishes your survey on the uterus. With the probe rotated for the transverse section of the uterus, you will now start angulating the probe towards the lateral pelvic wall to observe the ovaries. When you reach the ovaries, it's very important that you follow the soft tissue adnexal band so that any tubal pathology is not missed. Even the ectopics at all, if they are present, are not missed. You reach the ovary. As you reach the ovary, you will find out what is the long axis for the assessment of the measurements, and you will span across the entire ovary to count the antral follicles and to look for the pathologies. As for the measurement of the ovary, as I told you, when you have located the ovary, you have found the longest axis of the ovary. After that, you will measure the longest diameter, and the second diameter is measured as AP diameter, which is the longest diameter perpendicular to the transverse diameter. Then you rotate your probe 90 degree without any other movement and take the transverse measurement, and that is your side-to-side measurement of the ovary. The total ovarian volume is calculated as X into Y into Z into 0.523. The machine does it. The better way of measuring the ovarian volume may be a 3D, which we are going to talk about after a while. Coming to the uterine measurements, what is essential is to measure the effective endometrial length. And the effective endometrial length is the length of the, is measured by drawing a line, a trace from the fundal end of the endometrium extending to the external os. And this length must be mentioned on all your case papers, because this length is going to be your guide as to where to do the embryo transfers or how much length of the IUI catheter should be introduced beyond the external os. And this is called the endometrial length. The second important measurement is the endometrial thickness. And remember, though you are seeing the uterus, the entire uterus on that plane, the endometrium is also well seen. You should never measure the endometrium here, because here the endometrium is not perpendicular to the sound beam. The sound beam is in this direction, and here the endometrium is at an angle, so you are not seeing the margins as sharp as you would see when the endometrium is in the center. So always bring the endometrium in the center and then measure the endometrial thickness. It's measured from the outer margin of the endometrium to the outer margin of the endometrium and perpendicular to the central line. So why I'm talking so precisely about the measurements is that we often do wrong measurements, and then we have a false impression the endometrial thickness was more and I didn't get a pregnancy, or the follicular size was so-and-so and I didn't get a pregnancy, or the ovarian volume was so-and-so and this turned out to be a PCO. So standardized measurements are very, very important. Having done that, we have to then do an in and out movement of the probe to observe the sliding of the bowel loops on the uterus or the sliding of the ovary against the bowel loops as well as the uterus. to assure that there are no adhesions. And when there are no adhesions, you almost rule out the possibility of any endometriosis, or if there is a previous history of surgery, fibrosis, or adhesions. Of course, adhesions may also be due to chronic inflammatory processes, and you rule out that too. So most of the times, if your mobilization sign or the sliding organ sign is positive, the tubo-ovarian relationship is mostly going to be normal. So it must be checked for the uterus, must be checked for the tubes, for both the ovaries. To complete the basic pelvic ultrasound, it is essential to do the Doppler also. And on the Doppler, you need to find out the uterine artery to assess its resistance, its pulsatility index during the baseline scan, during the preovulatory scan. Also, you also need to check the spiral artery flow, the endometrial vessels. You also need to check the ovarian stromal flow and the perifollicular vessels. And how do you do this is important. We know that when we are doing an abdominal scan, we will go to the iliac arteries and angulate our probe medially to find out the crossing over of the uterine over the iliac vessels. But when you're doing a vaginal scan, you have to locate the uterines as you slide the probe longitudinally across the uterus. And as you can see here, that is the uterus. From the midline, as I'm going to the side, I'll see a tubular serpiginous structure appearing. Just watch over here. Serpiginous structure appearing there, and that is the uterine artery. So I can see the uterine artery entering from there and curving across like that. And that is where you're going to measure the flow at the entry of the uterine artery into the uterus. Doppler makes it a little more easier to locate that uterine artery, and you can see it here. Of course, it is true that you can measure the flow here, right here at the entry, or even a little farther, but it is important that you measure the flow before the artery bifurcates. That is how you measure the uterine artery. For the ovarian stromal flow, remember the stromal vessels are only those vessels which lie right in the center of the stroma. And as you rotate the probe, you have to confirm it is not a part of the main ovarian artery, because the blood flow in the main ovarian artery is going to be much more than that into the stroma. So that means you have to locate the ovary, you put on the color box to fill up the entire ovary, and then you will see for the blood flows. For example, you can actually see that this vessel is the main ovarian artery, and you will not measure the flow into this artery, but as you go further, you're seeing the bifurcation, and you can measure the flow on any of those vessels, which can be considered as the stromal vessels. So it is the stromal vessel flow that you are concerned with, and that is where you will measure the parameters. For the perifollicular flow, it's very, very important that you only see the blood vessels or measure the blood flow in the blood vessels which actually overlap on the follicular wall. If you are seeing the vessel and you are seeing the follicular wall separately, these are not perifollicular vessels. Remember, you have to measure the flow in these vessels, not in these vessels. If I'm seeing the vessels like this all around, I'll say there is no flow in the follicles. It's only these vessels which are perifollicular to this, and these vessels which are perifollicular to this. So that is very, very important. And lastly, the endometrial flow. Remember, when you're seeing the endometrial flows, you have to make your box size, the color box size, as small as possible, just to include the upper half of the endometrium, because that is where the implantation is going to occur, and you only want to assess the blood flows in that part. To get the flows so good, it is essential that you set your machine right. And to set your machine right, what is important? The first and the foremost is you select a correct preset. We are very lucky now. We have different probe settings, and along with the different probe settings, we have different presets. You can select a correct preset to be used for a particular application. You can have a separate preset for infertility. You have to, in spite of selecting the correct preset, you have to, time to time, change the angle and the depth, focal zone and the zoom. As you enter, into the pelvis, you have a completely wide open scanning field. But as you locate the organ of your interest, you have to bring it in the center of the image. As you can see, the ovary is there in the center, and then you have to decrease the angle to improve the frame rate, and you also decrease the depth so that the ovary appears not here but somewhere here, it appears larger. And then if required, you can adjust this. Arrow is for the focal zone. You can have to adjust it at the level of area of interest, and if required, you can add zoom to it. After that, you can switch on the color onto that if required. As you switch on the color, you need to set your color settings, your power Doppler settings, and your spectral Doppler settings. And for the color and the power Doppler, you have to look for the gains, PRF, wall filter, and the balance. And for the spectral Doppler, apart from this, what is important is the sample volume and the angle. I am not going to take you into the entire physics. I'm just going to give you quick tips, because this is what you are not going to adjust. You only can tell your application specialist, okay, make this settings the way I'm telling you, and it will be done. It will be saved into the preset and you can use it forever. It is very important to understand that PRF, which is called a pulse repetition frequency, must be adjusted according to the velocity of the blood vessel you are going to assess. That means if we are looking at the uterine arteries, if we have a high velocity blood flow, and for that you need a high PRF. But if you're looking at the follicular vessels and the endometrial vessels, which have a low PRF, for these vessels, the PRF has to be low. If the blood flow is a low velocity blood flow and you're selecting a high velocity, high PRF, look at that. Both the pictures are of the same patient, same time, but here you're seeing very few blood vessels because the PRF is high, and here you're seeing pretty more because the PRF is optimal. So the second important thing is the gains. If the gains are too much, you'll actually see the color spilling outside the blood vessels. Whereas if the gains are too low, you will not see the color even where there is blood flow. That means your gain settings should be optimum to show you all the blood vessels filled completely. Similarly, the wall motion filter. If the wall motion filter is normal, you will see normal feeling of the blood vessels. But if the wall motion filter is set at high, you will not see blood flow even when there is blood flow. So those two settings are again important for the color and the power Doppler. For the pulse wave Doppler also, the spectral Doppler also, the first and the foremost is the gains. As you can see here, as the gains increase, the unnecessary shadows increase. And this actually causes corruption of the actual spectrum. Moreover, if the gains are too low, in that case, you will not even see the full intensity of the spectrum. And in these cases, it is again difficult to assess the exact flow. Therefore, gains should be set to just get a nice bold spectrum, as you will usually see there. The wall motion filter, if it is high, you will see black line between the spectrum and the baseline. And this is never to be accepted, because if you are seeing a black line between the baseline and the spectrum, it is likely that you are going to miss low velocity diastolic flow. You will erroneously diagnose absent diastolic flow. Coming to PRF, just like for the color and the power, for high velocity flow, you need a higher PRF. For low velocity flow, you need a lower PRF. If you are using a low velocity, if you are using a low PRF for a high velocity flow, your highest velocities will be cut off. And if instead you are using a very high PRF for a low velocity blood flows, you will hardly see the difference between the systolic and the diastolic, and you will miss the flow for the venous at times if it is a low velocity flow. So those are the settings important. The angle correction is actually required only when you have to measure the correct velocities, which for us is only required for the perifollicular flow and the stromal flows in the ovaries. Our work therefore is much more simpler, because we don't have to correct the angle for all the Dopplers that we do, but it is important to understand that as I'm changing the Doppler, you can see a yellow line here, a short yellow line, and you can see it changing. And as that line changes, you can see there is a gross difference in the peak systolic velocity and the end diastolic velocity happening. That means that as the angle changes, there is erroneous measurements of the velocities, and therefore the angle correction is required. If I say so, these settings are to be done, then what should be the settings? So this just one picture for you is just enough to tell your application person, okay, set my infertility preset with these settings. And there, the color and the power, the PRF has to be 0.3, the wall filter has to be low 1, and adequate balance and gains are to be set. For the pulse wave Doppler, the PRF has to be 0.9 to 1.3, wall filter 30 Hertz, and adequate balance and gains, and the sample volume should be 2 millimeters. Now, I know that I have deviated myself from the actual ultrasound monitoring to the settings and to the actual technique. And this is purposefully done because unless you master the correct technique, all your findings are going to be erroneous, and then they are not going to give you the expected results for your cycles. Now, coming to the actual assessment, we will divide this discussion into a baseline scan where we want to assess the ovarian reserve and the response, and to decide the stimulation protocols. And that is why I told you Dr. Asha had made my work quite easy. The second scan is done pre-ovulatory to assess the follicular maturity and the endometrial receptivity, and you also need to assess the luteal phase, and we will discuss why. Coming first to the ovarian reserve and response, Dr. Asha has beautifully told us that reserve and response are two different things. Reserve is assessed by the number of antral follicles and the ovarian volume, and that only tells you how many follicles you're likely to get at the end of stimulation. Whereas response tells you what doses of gonadotropins will be required to produce those number of follicles. And it is reserve, which depends on the antral follicle count and the ovarian volume, and it is the response which depends on the intra-ovarian stromal flow. And this assessment is to be done on the baseline scan and not later. That means day 2 and 3 of the cycle, when the estrogen and progesterone both are almost at their baseline levels, and even LHF, SH are not high. We have already discussed that to count the antral follicles, we will only scroll across the ovary. Remember, don't ever rotate the probe when you're counting the antral follicles, because if you rotate, you're going to overcount them. And if you just scroll across, you eyeball and count the number of antral follicles, it is as accurate as 3D according to a study by Jayaprakash. And this is true as long as the number of follicles are just about 12 to 15, because your eyes can be quite accurate till then. But if the number of follicles are more, as in PCO patients, 3D can definitely give you more exact values. It has been shown that number of follicles of more than 12 millimeters on the day of oocyte retrieval correlated significantly with the antral follicle counted by 3D ultrasound rather than 2D ultrasound. And when you count them by 3D, the most sophisticated software these days used is the Sono AVC. It is a Sono automated volume calculation. Having acquired the 3D volume of the ovary, you just switch on the Sono AVC, as you can see by the square there coming up there. As you can see it by the square coming up there, and you select the right or the left ovary, and the machine within seconds defines all the follicles for you. You can see that there is some overcounting on the size of the follicles, and this can be processed by what is called post-processing. You can cut, merge, add, or remove the follicles. You can see it happening there on the video. And this ultimately gives you the exact number and the size of all the follicles. And it gives you the entire list of the follicles, their sizes, their numbers, their XYZ diameter and their volume, and the mean diameter in a single result sheet. We will look at that a little later. Coming to first, importance of AFC. I'm sure Dr. Asha has really shown us the way. Like to add a little bit to that. Number of retrieved oocytes correlated with the antral follicle count and the ovarian volume, and these are the direct parameters for assessing the ovarian reserve. Antral follicle count and the ovarian volume showed very good correlation with AMH. Serum AMH levels have been shown to strongly correlate with the number of antral follicles and have appeared to be cycle independent. It is this small antral follicles, 2 to 6 millimeters, which actually represent the functional ovarian reserve even in young women. If you find low AFC, it means a low reserve. But as she rightly said, in this patients, the FORT and FOI are going to be much better. So when you combine age and AFC, it gives you actual results. But AFC in this women also means low reserve. In cases with poor response, AFC is considered to have the best discriminating potential for a response compared to the total ovarian volume. Basal serum levels of FSH beyond day 3. When you use a combined model of AFC and AMH, and only AFC or only AMH, it was found that the combined model had almost similar effectivity and accuracy as the model with AFC alone. Even a meta-analysis has shown that AMH has at least the same level of accuracy and clinical value for the prediction of the poor response and non-pregnancy as AFC. That means in that meta-analysis, AFC is even proved to be better than AMH. So that's about the poor response. In the hyper response cases, AFC is used to predict the hyper response and it can give us safe, successful stimulation regimes. AFC and AMH are equally accurate predictors of excessive response. And in one study done by us, where we compared AFC and AMH in 2 groups, normal reserve groups and the PCO. For the 2 end results, the number of oocytes retrieved and the number of follicles larger than 12 millimeter on the day of trigger, both the parameters for both the results in both the groups, almost proved equally accurate. And therefore, we are using only AFC for the assessment of the ovarian reserve. AMH does not appear to be helpful for all subjects in PCOS. So even in PCOS, only in anovulatory patients, AMH is considered to be better, but AFC is highly sensitive in all the phenotypes of PCOS. And a 4th special case. So we have seen poor response, hyper response, PCO patients, and we are also seeing in endometriosis where we usually expect a poor response. In this patients also, the number of mature oocytes retrieved in the women with and without endometriosis have been predicted well by AFC and AMH, but only AFC was a predictor in women with previous endometrioma surgeries. Multivariate analysis has confirmed that AFC represents the most useful ovarian response marker to the controlled ovarian stimulation, and serum AMH most robustly correlates with AFC rather than all the other hormonal parameters. Moreover, the 2 do not give a mutually exclusive information, and therefore considering only AMH for the assessment of the ovarian reserve to decide the stimulation protocol should be considered sufficient for all practical purposes. Ovarian volume is the second one, and we all know that smaller ovaries are likely to give us poor response, and therefore cancellation of the cycles is more, whereas larger ovaries are associated with PCO and hyper response. Number of the retrieved oocytes correlated best with the ovarian volume and the antral follicle. But that is about the reserve. Coming to the response, measurement of the ovarian stromal flow in the follicular phase is related to the subsequent ovarian response in the IVF treatment, and we have already discussed how to measure the stromal flow, and just to repeat, we have to have correct settings for the same. When you measure the ovarian stromal flow, The VI, FI, and VFI, the vascularity index, the flow index, and the vascularity flow index of the ovary were significantly related to the ovarian response to stimulation. What are these parameters? These are 3D power Doppler parameters which tell us about the global vascularity of a structure. Vascularity index tells us about the abundance of the flow in that volume. Flow index tells us about the average intensity of the flow. And vascularity flow index tells us about the perfusion. It's a composite value of the two previous indexes. So that means if the VI, FI, VFI are more, the patient is a hyper responder because the flow in the ovary is good. This can be very simply measured by just taking an ovarian volume with a power Doppler. The software which is called vocal is applied to measure the volume. We are going to see it with the follicle, how the vocal works. And then you just have to press a knob which is called a volume histogram. You will get the VI, FI, and the VFI values. And this plays a very important role to tell you whether this patient is a hyper responder or a poor responder, which require higher doses for stimulation, lower doses for stimulation. Professor Kupasik et al. Have also shown that the patients who had a higher FI had a risk of OHSS, where those who had a lower FI were poor responders. Even in patients with endometriosis, where we usually suspect a poor response in these patients also, if the flow in the ovary is good, the patients will respond good to stimulation. And there is a logical explanation for that. If the flow to the ovary is more, actually, a part of this has been already discussed by Dr. Asha, but if the flow to the ovary is more, that means more percentage of total gonadotropins is being supplied, is being delivered to the ovary, and therefore total doses required to be pushed into the patient's system will be less. Whereas if the flow to the ovary is less percentage of the total amount loaded into the patient's system flows into the ovary, and therefore to stimulate that ovary, you still have to put more doses into the patient's system. That means patient who have more flows in the ovary is a hyper responder, lesser flows in the ovary is a poor responder. And this is not only proved for the 3D power Doppler studies, even for the routine 2D measurements like parameters like PSV, peak systolic velocity. It's also been shown that if the PSV is higher, patient is a hyper responder. Excuse me. The ovarian stromal RI, if it's less than 0.58 and the PSV is more than 10 centimeters per second, the patient is a hyper responder. If the RI is between 0.6 and 0.7 and PSV is between 5 and 10, patient is a normal responder. And if RI is is more than 0.7 and the PSV is less than 5, the patient is a poor responder. This is what has been found from the literature and from our experience also. What is this RI? And what is that PI? I'm sure most of you know, but still, RI and PI are the measurements of a resistance in a particular vessel. RI is measured as systolic minus diastolic, so systolic minus diastolic divided by systolic. In these cases, when the diastolic flow reaches 0, the RI value becomes 1 and the diastolic flow becomes 0 in only very high resistance vessels like in uterines. When the RI becomes 1, beyond that, when the resistance increases, then the systolic flow also starts decreasing, but this value is 0 and therefore the RI does not increase beyond 1 and therefore you cannot document the increase in resistance. Therefore, for all the high resistance vessels, we use PI, where PI is calculated as systolic minus diastolic divided by the temporal average velocity of the entire cardiac cycle. And this will allow a comparative value for any amount of increase in resistance in a blood flow. So for the uterines, we will use PI. For the endometrial and the follicular vessels, we will use RI. Now, if I'm saying that enteral follicle count and the ovarian flow parameters and the ovarian volume can be confidently used for assessment or for deciding the stimulation protocols, there is also a literature evidence to that, quite old, and that had also said that the number of antral follicles, the ovarian stromal FI, the ovarian stromal area, and the ovarian volume are the 4 parameters which can decide the ovarian reserve and response and can be used as deciding factors for the stimulation protocols, and they are of importance in the same order. Using this knowledge, quite of our pilot studies, we have derived certain values which tell us that if these values are present, the patient will require higher doses for stimulation. If those are the values, patient will require lower doses for stimulation, including age, BMI, antral follicle count, ovarian volume, stromal RI, and stromal PSV. But that is quite random. So we have devised a scoring system, which is called a baseline score system, wherein all those parameters which demand higher doses for stimulation, that means which indicate poor response, is given a lower score, and all those parameter values which say this is a hyper responding ovary, or these are the patients who require lower doses for stimulation, they are given a higher score. So poor responders, poor score; hyper responders, higher score. As you do your baseline scan, you find out the values, you put them into the relevant boxes, and you do a total to find out what is the collective score of that patient. Depending on what is the score, we have devised starting doses for IUIs and for IVFs using recombinant FSH. We know that the follicular dominance is achieved on day 5 of the cycle in a natural cycle, but even in a stimulated cycle, on day 5 of gonadotrophin stimulation in IVF cycles, we expect the follicle to grow to dominance. In IUI cycles, if it is a combined stimulation, letrozole plus gonadotropin, in these cases, we may get a dominant follicle on day 5 or day 7. And in these patients, when you start gonadotropins, you might already have a dominant follicle, but when we start gonadotropin stimulation, we always see this patient on the day of starting stimulation and then on day 5 of stimulation, provided on the day you start stimulation, all the follicles are smaller than 8 or 9 millimeters. That means none of the follicle is dominant. If you are seeing already a dominant follicle on the day you start gonadotropin, this happens only when it is a gonadotropin and it's a letrozole and gonadotropin cycle, and you are doing a scan on day 7. In these cases, depending on the size of the follicle, you will call the patient on day 3 or 4 of stimulation, expecting the normal growth rate of the follicle, and the normal growth rate of a dominant follicle is 2 to 3 millimeters a day. For example, if it's an IUI cycle, if I've given letrozole, I'm seeing the patient on day 7, the follicle is already 12 millimeters, I'm going to start gonadotropin, I'll call her just after 2 days. But if it was 10 millimeters, I'll call her after 5 days. Now, when you see her after 5 days or the 5th day of the stimulation, if there is no response, that means the follicles have not grown beyond dominance and it's an IUI cycle and the score was less than 10, I would increase the dose on the day 5 itself, 75 IU. If the score was between 10 and 20, I will add 37.5 to 75 units of RFSH on day 7, not on day 5, on day 7 of the stimulation. Score was between 20 and 22. PCO patients, I will not increase the dose till day 10, and when I increase, I only increase 37.5. And when the score is more than 22, I'll only increase on day 40 and half of the starting dose and not more than that. But beware. Only absence of follicular growth does not tell us that the patient is not responding. if the follicle or the endometrium, one of the two is growing, that means the patient is responding, because even when the endometrium is growing, it indicates that the estrogen level is rising, and that estrogen is produced by the granulosa cells, and that estrogen is produced from the granulosa cells under the effect of FSH. That means if one of the two is growing, patient is responding, don't increase the dose, continue with the same dose. In the IVF cycles, we always start stimulation day 2, or we always see on day 5 or 6 of the stimulation. And if there was no response and the baseline score was less than 10, that's when we add LH to stimulation. Score was between 10 and 20, we add only 75 IU of RFSH. Score more than 20, we add only 37.5 international units of RFSH. Now, if you have seen, it's only in the low score group in IVF patients that we add LH. And why is that so? If the score is very low, that means all the parameters are low. That means AFC and volume are also low, and the RI and the PSV are also low. That means the flow is also low. And it's a very important, and this is again mentioned by Dr. Asha also, that apart from VEGF, apart from IGF, it's also LH which is responsible for the vascularity of the ovarian stroma. It's LH which leads to neoangiogenesis, catecholaminergic stimulation, leukocyte-cytokine activation. Therefore, it leads to more blood vessel formation, and it also leads to lower resistance flow. That means if the LH is sufficient, then it means, if the blood flow in the ovary is good, it means that the patient is a good responder, and it also means that the LH is sufficiently reaching the relevant tissues, and therefore LH supplementation is not required. But if the blood flows to the ovary is less, in these cases, the ovary will respond poor. It also means that either the LH is low, or there's a polymorphism, or there's a receptor defect, and therefore, or it has a lower bioactivity, and therefore in these patients the LH supplementation is required. And this exactly matches to again what is discussed, the Poseidon group 1 and 2. According to the study, you first see that the parameters, the reserve parameters are normal. You start stimulation, patient does not respond. Next cycle you add LH, just because in these studies the vascular parameters are not seen. If the vascular parameters were seen, we would have diagnosed this earlier. We would have started LH in the beginning of the cycle, not after one failure. And these protocols have been proved to be very, very successful, because it gives an extremely low OHSS rates, and it has very low cancellation rates for poor response also. One more thing is important for the precise management of the stimulation protocols, and that is looking at the size of the follicles at the start of stimulation. If all the follicles are smaller than 8 or 9 millimeters on the day of start of stimulation, lesser than 6 or 7 millimeters on the day of start of stimulation, these are the follicles which do not have FS receptors, and they will not respond to FS. Therefore, in these patients, when you do Hello? Am I audible? Okay. So, it is very important that you also assess the size of follicles when the stimulation is started. It is also essential to look at the endometrium on the baseline scan. It should not have any flows. If it has flows, it either means it is infected, or it has already higher estrogen and progesterone levels, the cause of which can be found looking at the ovary. It may show a mature follicle or a dominant follicle, or it may show an active corpus luteum. As the follicle grows, its fate depends on not only its look, Lack of internal echogenicity is thin walls, but it also depends on its growth rate. Dynamicity is very, very important. As it grows, it regresses the follicles surrounding it because it pulls all the blood vessels towards itself, and therefore the rest of the follicles are not growing to grow. As the follicle grows beyond dominance, the vascularity starts increasing, and the vascularity reaches maximum about 2 days before the ovulation occurs. On the say 24 to 36 hours before the ovulation, you'll see a hypoechoic halo and you'll see a tiny cumulus-like shadow. This cumulus-like shadow is much You will also see some low-level echoes parallel to the follicular wall, and this indicates impending ovulation. This occurs about 6 to 10 hours after the ovulation, before the ovulation. When there are multiple follicles, you cannot measure the diameters of all, and in all these cases, it is best to use Sono AVC with 3D, which gives you size and size of all the follicles and the total number of follicles very, very easily. As I told you, with the rise in, with a peak in the estrogen, the RI of the follicle reaches the minimum, and at when you call the follicle to be functionally mature, when the surge is going to start, vascularity should cover 3/4 of the follicle circumference. The RI should be less than 0.5, and the PSV should be more than 10 centimeters per second. And these flow parameters are very, very important, because if the flow parameters are not good, the ovum inside is hypoxic, and there is a high chance of chromosomal abnormalities, and there are multiple studies to say the same. Whereas if the flows are better, the chances of getting pregnancies are much better naturally, because flows are more, because the estrogen is more, and that means the follicular quality is high. It's very important that the follicular vascularity should cover only 3/4 of the circumference, not more than that, because the site from which the ovulation is going to occur is purposefully deprived of vascularity to avoid the hemorrhage. You can measure the follicular volume and the vascularity bivocal by taking a 3D volume. You do vocal, which is measuring the ovarian volume by this software, which draws the follicular circumference several times, rotating it 180 degrees, and then finally calculating the volume of the follicle. And after the volume of the follicle is calculated, a shell thickness of 2 millimeters is selected, and in that the vascularity of the follicle can be evaluated either quantitatively by VIFI, VFI, or you can see the vascularity subjectively by the NGO mode, as you can see there. Get much better results. In fact, if I tell you my experience, when you move from 2D to 3D, your results, your IUI and ART results both improve by about 20 to 25%, whereas when you move from the 2D to 3D, there's a further increase by 10 to 15% in your results. So it is important to look at the 3D and the 3D power Doppler parameters when you have failures with the Dopplers also. We have discussed all these points. This is just a summarizing slide for the follicular parameters. What happens after the surge? After the surge, we know that the LH rises, and there is also a slight progesterone rise. So these are the two important things that occur. With the LH rise, there is an increase in the PSV of the reaches as high as 45 centimeters per second just an hour before rupture. That means if you are getting a higher PSV with a lower RI, that means you are closer to the rupture. You are not, so you are somewhere here on the surge, you are not here. And that indicates that you should do there is a likelihood of an early follicular rupture, and therefore you should do an early IUI. And according to that study of ours, in all those patients who had PSP of more than 20, no matter what was the stimulation protocol, CC, letrozole plus RFSH or RFSH, when the PSP was more than 20, the double IUI pregnancy rate, which is shown by yellow bars, are much taller than single IUI rate, which is shown by the red bar, and therefore all those patients who had a PSP of more than 20 should be offered double IUI, one at 12 to 14 hours and the second at 36 to 38 hours after the rupture. Correlating this with the endometrial behavior, as the estrogen starts rising, the endometrium becomes multilayered as early as day 6 of the cycle. When usually there's a single follicle, you'll get a grade B endometrium where you have multilayered pattern with intervening area which is hypoechoic or anechoic. When you have 2, 3, 4 follicles, when that means estradiol level approximately is 300 to 700-800, you will get grade A endometrium, which is multilayered with echogenicities in between the lines, not more than that of the normal myometrium. And if it is truly supraphysiological levels of estrogen, you will get isoechoic homogeneous endometrium. So before the rupture, the endometrium may be anything, but it indirectly tells about the follicular quality, because if you have multiple follicles and you still have a grade B endometrium, that means the follicles do not produce sufficient estrogen. But you have 2 or 3 follicles and you have a nice grade A endometrium, it means it is a very good follicular quality. So estrogen in the endometrium represents as increase in thickness, improving in morphology, increase in vascularity, and the cervical mucus. The vascularity endometrium also starts growing the same time when the follicular vascularity starts developing, and it reaches maximum 3 days before the ovulation. This vascularity, when it reaches the inner layers of the endometrium, it is called zone 3 and zone 4 vascularity, and it is this vascularity which is essential for the implantation to occur. Sorry for that interruption again. So if this vascularity is not present, there is a high chance of miscarriages, and therefore zone 3 and zone 4 vascularity is absolutely essential before you do a transfer. For this case, I would just tell you a very recent experience of ours. We were just evaluating our last 50 pregnancies. And what we found that all those patients who had vascularity in zone 3 and 4 present, frozen transfer cycles. Vascularity in zone 3 present before the progesterone was started, 80% was the conception rate, frozen embryo transfers. And this is therefore very, very important. The endometrial volume calculation is important when the endometrium is persistently thin, and if the volume reaches 2 milliliters, in these cases, the chances of implantation are extremely good. And all the 3D power Doppler parameters have also shown better the vascularity, higher is the chance of conception. Whether it is in the form of VI, whether it's in the form of FI or low resistance or even BFI. Now, if I say this, the Cochrane says that the vascularity cannot be directly correlated with the implantation rates, and this is also true because the implantation is a function of the endometrium and the embryo together. If the endometrium is very good and the embryo is poor, the implantation is still likely. If the endometrium is poor and the embryo is very good, then also the implantation is likely. But if both are poor, the implantation is not possible. And therefore, it is mentioned very well in this paper, which says that the correlation of Doppler indices and pregnancy outcome has been demonstrated when non-grade 1 embryos are being transferred. So, and there is a lot of literature proof on what we have just discussed about the vascularity of the endometrium and the implantation rates. It's also essential to look at the uterine artery PI, and it should be always less than 3.2 coming to a real summarizing slide, which tells us that you can actually predict ovulation in your IUI cycles. The endometrial vascularity, which starts 3 days before. It is the RI of the follicle, which falls 48 hours before. 24 to 36 hours before, you'll get a cumulus-like shadow and a hypoechoic halo. 29 hours before, you'll have a shoot up in the PSV. And 6 to 10 hours, you'll see the low-level internal echo. So you can actually time the ovulation and time your IUI accordingly. Just like in the follicle, with the start of the surge, there is an increase in the PSV. In the uterine artery, there is increase in the resistance, because this is the period when the estrogen and progesterone both are low, and therefore there is an increase in the uterine artery resistance. There is decrease in the endometrial receptivity immediately after the peak of the surge, and therefore, if you get a high uterine artery resistance, you always have to look for the follicular PSV. If the follicular PSV is high, that means the surge is imminent and the rupture is imminent, and you should do double IUI. But if the follicular PSV is low, which means the follicle is still not mature, and you should wait, continue the stimulation and do an IUI or give a trigger after a day or two, even if it's an IVF cycle. Here it's very clear that the progesterone starts increasing just immediately after the ovulation, or just before the ovulation actually starts. And therefore, before the ovulation starts, you actually start seeing a fluffiness of the outer margin of the endometrium. And this indicates physiological level of progesterone and physiological duration of progesterone exposure to the endometrium. That means if you're considering that 1.5 nanogram of progesterone, you actually don't need to see in the blood, because the blood level may be anything, but whether it is perceived in the endometrium the correct way or not can be recognized by the endometrial pattern. As long as the endometrial pattern is just fluffy outer margin, the progesterone exposure is physiological, within physiological limits. But if the outer margin of the endometrium starts becoming hyperechoic, that means the receptivity is decreased, the progesterone level and the duration are both, or one of the two, is pathological, and therefore you should not do the transfer. As the luteal phase advances, this echogenicity progresses towards the center, and the entire endometrium becomes hyperechoic only in the mid-luteal phase. Similarly, the vascularity also is highest pre-trigger. It is low immediately post-ovulatory, and then again increases in the mid-luteal phase to reach the maximum. If the total number of follicles we know are too many, as we know estrogen levels more than 4,000 in IVF cycles, in these cases we are not going, or more than 11 follicles, more than 25 follicles of larger than 11 millimeters size. We are not going to give an HCG as a trigger, or not even going to supplement the GnRH trigger, agonist trigger with 100 or 1,000 or 1,500 units of HCG. This follicular sizes and the number of follicles can be easily calculated using a 3D with a Sono ABC. The normal corpus luteum in the mid-luteal phase should have an RI of less than 0.5, and that tells you that the progesterone production is nominal. Along with that, if you see the endometrium with good secretory changes on 2D, hyperechoic, with vascularity reaching the inner layers, with an RI of less than 0.5, and the uterine artery PR less than 2.5, you know that the progesterone is well perceived by the endometrium, and therefore the luteal phase is normal. Instead, if it is a luteinized unruptured follicle, you will have high perifollicular resistance. I call it a follicle because it is not ruptured, it doesn't have hemorrhage inside, it is still a follicle. It has hyperechoic walls and low-level internal echogenicities. The endometrium shows echogenicity, but no thickening, and it shows low vascularity also. If it is a luteal phase defect because of inadequacy of the corpus luteum, you will not see the corpus luteum flow sufficiently. You will have a thin endometrium and hypovascular endometrium. Whereas if it is a normal corpus luteum but inadequate receptors, progesterone receptors in the endometrium, you'll have a normal corpus luteal flow but thin and hypovascular endometrium. That means you can actually diagnose the luteal phase abnormalities also. Quickly going to, in 2 minutes, tricky situations during the cycle monitoring. You have a follicle larger than 10 millimeter on day 2 or 3 of the cycle. What does it mean? It means that the that the FSH is high, basal FSH is high. Why? Because we know that the follicle growth beyond 8 or 9 millimeters is only dependent on the FSH, and that means that the ovary is aging. If the ovary is aging, then you actually need to be more aggressive on your treatment, and that's how you can take a decision for the further treatment. But this may also be a residual follicle of the previous cycle. As you put on the blood flow, if there is a perifollicular blood flow, then it is an active follicle. If it shows no blood flow, that means it's a residual follicle of the previous cycle. Since it's not showing any flow, it will not affect your stimulation. You can start stimulation. If there's a thin endometrium in the pre-ovulatory phase, the first and the foremost is, in spite of a larger follicle, it is an immature follicle because the flows are still not there and the endometrium is thin. But in spite of a normal follicle, if you still have a thin endometrium, you have to look at the junctional zone. That means the outer hypoechoic line on surrounding the endometrium. If the junctional zone is intact, it may be Escherman or it may be hyperprolactinemia, but that occurs only in the CC cycles chiefly or in the true hyperprolactinemia states. And it should be treated accordingly. If it's an altered junctional zone, it may be either chronic endometritis or it may be adenomyosis. In adenomyosis, myometrium also shows abnormalities. Instead, if you have a pre-ovulatory thick endometrium with no mature follicle, that means it is either a PCO patient and you still have a triple line endometrium, or there has been a recent rupture and therefore you are seeing a fluffy endometrium. So that tells you about the thick endometrium with no follicle in the pre-ovulatory phase. And lastly, non-rupture of the follicle with a trigger. It's very important to remember that the follicle responds to LH in different ways at different sizes and different maturities. We know that the follicles which are mature with LH surge is going to trigger. But those follicles which are suboptimally mature, which are grown up in size but they do not show enough flows, that means they do not have sufficient LH receptors, and these follicles, they go into LUF. Whereas those follicles which are smaller than 14 millimeters they actually share FSH and LH receptors and they'll further grow with LH. That means when the follicle was suboptimally mature, it may go into LUF, or when the surge is inadequate, it will go into LUF. So you know what to do for the further cycles. Where B mode ultrasound only tells us about the anatomical status of the follicle and the endometrium, it is the Doppler that speaks about the functional status and the hormonal changes. 3D adds to the global assessment of the follicle and the endometrium, and therefore ultrasound is the way to success of your ERTs and your successful treatments. Thank you very much.
Thank you for the wonderful session, ma'am. So we
Thank you.
Can we take up the question and answer session now?
Sure.
Now, the first question is how to manage a persistent poor endometrial flow in FET cycle in spite of all adjuvants to improve the flow.
When you have already added all the adjuvants and you still don't get a good flow for a frozen embryo transfer, the last resort, of course, is, after you have already tried aspirin, you have tried all those antioxidants, you have tried all those capillary enhancing drugs, you have already added GCSF, and still it doesn't work, stem cell is the answer. But I would like to tell you, and we were the first people to do the stem cell, not only to do the stem cell transfers, to get the first pregnancy after the endometrial regeneration with stem cells way back in 2011. But the only thing is that we do not get very good results with tuberculous endometrium. Otherwise, with Escherman, etc., the stem cell does give a very good result.
The second question is, can you explain little on luteinized unruptured follicle and corrections to be done in the next cycle?
Okay. So as I just discussed, the luteinized unruptured follicle occurs in two cases. One, the follicle was suboptimally mature. That means it is grown up, but it does not have sufficient LH receptors, and you have given a trigger. So the LH rises, but it's not perceived by the follicle sufficiently, and therefore it goes into LUF. The second possibility is that you have given a surge which have proved to be inadequate. How does that happen? Especially when you're using urinary products. It's possible that if you have used 5,000, the actual dose inside may be even less and may have proved insufficient for the trigger. Or sometimes it happens that if you have given the patient for self-administration, either the cold chain is not maintained or the patient might have wasted a part of it or have missed it totally. And in these cases, the follicles will not rupture and it will go into LUF. When the follicle goes into LUF, the outer margin starts getting hyper-echoic and you start getting low-level echoes inside the follicle. This is the 2D sign that the follicle has not ruptured and gone into LUF. Remember that when you say LUF, it is an unruptured follicle and you will never get hemorrhagic shadows inside like those fishnet appearance or layering fluid and things like that. You'll never get them. Moreover, because the corpus luteal flow or the flow around or in the ovary is dependent on the progesterone levels. That means if the progesterone levels are good, the RI of the pericorpus luteal flow is going to be low. Similarly, if the follicle has gone into LUF, the progesterone production is definitely less because there are fewer cells, fewer granulosa cells which have converted into active theca cells, and therefore the RI surrounding this LUF is going to be much higher than what you find in normal corpus luteum. In normal corpus luteum, it's less than 0.5, whereas in LUF, it's usually in the range of 0.50 to 53 to 0.59. You asked me what to do in the next cycle. It is very essential that in the next cycle, you must do a proper follicular monitoring, and the trigger is not to be given unless you see good blood flow surrounding the follicle. 1. 2, you have to decide the exact product that you are going to use for the trigger. It's best to use recombinant ones, and it is best to assure that it is being injected in the correct way at the correct time. That's it. Hello? Hello?
Thank you, ma'am. And the last question is, in unexplained recurrent pregnancy loss, natural conception with mild adenomyotic uterus, can we go for a downregulation with oral denogest and start the stimulation?
This actually is not a question for me, but I would just say this, that in patients with recurrent, because I will talk only related to ultrasound, in patients with recurrent pregnancy losses, early pregnancy losses, it is very essential that you only start progesterone after the endometrium has grown to at least 6 or 7 millimeters, or the endometrial volume is at least 2.5 to 3 ml, and the vascularity is reaching zone 3 with an RI of less than 0.6. And after that, if you can do the transfer, start progesterone and do the transfers, the result will be very good. You can add aspirin or heparin if at all there is an indication for the same.
Thank you, ma'am. Thank you, Dr. Sonal Panchal, ma'am, for such an informative session. You have explained in detail about knobology, setting of color doctor, and assessment of AFC. Beautifully explained the role of assessing the ovarian vascularity and predicting the ovarian response and adjusting the gonadotropin dose. It helps to improve the scanning skill and also to improve the success rate in ART. Thank you, ma'am. Thank you very much.
Thank you.
Next, I would like to introduce our next speaker, Dr. Sripada Jogarao, sir. Dr. Sripada Jogarao, sir, is a pioneer in the field of medico-legal aspects, especially in the field of infertility. third-party reproduction and surrogacy. He is a postdoctoral research scholar in the healthcare law and ethics. He has been awarded globally acclaimed Max Planck Fellowship by Max Planck Institute, Germany. His teaching career started 3 decades ago. He was the founding faculty member for about 15 years in the premier National Law School of India University. He still continues to teach at the National Law School of India University as a visiting professor. He is deeply passionate about medical legal as challenges in the discipline of healthcare ethics and law. He has authored a number of publications by reputed institutes and he has actively participated in several research projects. He is well-known author and very good speaker. He has delivered many lectures focusing on healthcare ethics and law. He is presently managing the professional activities of Legal Excel, a law firm of advocates, solicitors, and healthcare consultants. Now I invite Dr. Jogarao sir to speak on medical legal issues, a perspective in current context of COVID-19 and its aftermath. So you can start your session, sir.
Good afternoon, everyone. Thank you, Doctor. After two medical-oriented theme presentations, I would be now moving on to the medico-legal issues in this concluding presentation. I hope you are in a position to view my PPT. Is it clear?
Yes, sir.
Okay. Now,
Please do the slide share. Share the slides. Huh?
The slide show.
Slide.
I did.
Slide show, sir.
Slide show, sir.
Is it all right?
Yes,
Yes,
sir.
sir.
Yeah. Now, friends, the reason for choosing this particular topic is nothing but the context what we are experiencing. When Dr. Asha informed me about this particular webinar, I thought this is the right opportunity to share with you and interact with you on an area which apparently assuming a lot of significance. That is the reason why I thought I should share with you the medico-legal issues, a perspective in the current context of COVID-19 and how it would be in its aftermath as well. I think to begin with, our context in terms of our own experience needs some inputs in comparison. To me, this is crucial because globally, COVID-19 situation continue to have varied degrees of impact. For example, a couple of countries have experienced devastating impact. And a couple of other countries, per population number, if we take note, the impact, no doubt it is surging, particularly speaking for our own context. Definitely, we have not reached that stage. We may reach, depending upon last particularly 3 to 4 days upsurge that is taking place on a single day. Therefore, whatever we are going to discuss today, one thing we need to understand that we do not have, as matters stand, any experience in relation to medico-legal in terms of this context, largely due to successive lockdowns and almost non-functional dispensation. I'm sure you are aware, only of late the courts have started functioning in a very, very limited manner. As a result, what I personally thought was, even though there is no experience as such, considering the overall context and the impact, awareness and sensitization is something needed either to prevent or preempt certain consequences. Please do take note of that. As matters stand, what I propose to do is to identify certain issues which are potential and plausible in our context. This is the reason why I have selected certain case situations with an inherent question. That is how I thought I would initiate the presentation and interact with you. In the process, I'm very conscious of the fact that these issues may potentially be raised as a matter of legal risk. I think in the present context, every one of us, we are aware, COVID-19 related guidelines have been issued from time to time by both central and state governments. As we were discussing about a global presence, within India also, I'm sure you must have realized there are different states with varying numbers. The reasons may be very diverse and different. But having said, within the states also, certain districts, etc., etc. Therefore, the successive guidelines in terms of either during lockdown or unlock 1.2, all these guidelines, I think we must keep at the back of our mind, which is very, very essential, particularly to those doctors who started practicing. Therefore, in the backdrop of that particular nature, the guidelines, successive notifications, particularly Ministry of Home Affairs, etc., etc. Let me start with a particular case study so that we will be able to identify in what way the fact situations have been identified. In fact, when the lockdown started, a couple of my colleagues and friends, they used to raise one particular question. I remember very vividly the day on which the central government said about the OPDs, clinics, they can start functioning. That day itself, the question was, the issue, suppose if a patient on OPD basis approaches a particular clinic or nursing home, and it so happens thereafter the person or the patient realizes that he or she got infected with COVID. The question is there a legal risk for such hospital or nursing home or center whereby the infected person may approach and seek legal remedy? This is one important. Second related is, in fact, to this effect, I am told, and I did realize from a couple of other presentations as well, with regard to informed consent. Is there a need for context-specific informed consent? If so, what ought to be the content? Suppose if the person who approaches to avail certain services, either OT or IP basis, etc., if there is there a need for executing such an informed consent? The primary purpose of this particular informed consent is to inform and enable the party or the person to get to realize about the context and, more significantly, the possibility and the potential of getting infected. And accordingly, many people they have looked into and they have revised the protocol. Some of them they have introduced a particular COVID-related informed consent, etc. The related issue is, I do understand that some persons with knowledge and experience felt that there is no need for such kind of informed consent. But somehow I personally felt that the way the judicial interpretation that has taken place over a period of time in our own country, the legal need for introducing informed consent is more a context specific situation. Therefore, I am of the opinion, because the COVID context throws open challenges, particularly dealing with the life and health of the individual. Therefore, it is necessary to inform the person that these are the possible ramifications when once you take a decision to approach us and seek treatment, etc. Therefore, to that effect, I am of the opinion that there is a need for such a protocol, such a documentation. Now, by and large, the question is, if such a person approaches and gets infected, is there a legal remedy for that person? In that way, whether he or she can file a case against. And the related question is, say for instance, suppose if we have executed informed consent, still can there be a legal risk? I think these are the two issues have been raised by many. I think to this effect, my response would be as follows. To begin with, the content and the cautions and the precautions that have been envisaged by the respective guidelines must be put in place. Number one. Number two, the people who are expected to comply with those guidelines must necessarily be trained and given capacity building. Next, the most important thing is the communication aspect. The people who are meeting the patients or persons, they must communicate in a manner that they understand. In the backdrop of this, if there is a kind of complaints with regard to guidelines, the question to be looked into is whether the person still has a right to seek legal remedy. In my opinion, yes, the person has a right to seek legal remedy. However, whether accountability can be drawn against the doctor or the hospital is purely a question of fact. To that effect, a scrutiny need to take place with regard to whether guidelines have been complied in its letter and spirit or not. That's purely a question of fact. Whether there is any kind of negligence or deficiency of service, naturally these things need to be taken as a matter of evidence proof. Now, the related question informed consent. I always mention, in terms of informed consent, it itself is a matter of duty. Therefore, if that duty is discharged, that does not mean it acts as a shield to cover any possible potential deficiency of service. Therefore, on one hand, informed consents need to be executed, documented, and similarly, one has to ensure the guidelines and the standard of care in terms of preventing or spread of infection must be followed in its letter and spirit. If these two are there, then there is a very possibility the person seeking legal remedy may not be able to succeed. Therefore, even though we execute informed consent in a COVID-related situation, still there is a very possibility that the legal remedy, subject to the proof as to if at all there is any failure to provide a particular precaution or failure to deploy a particular standard of care, etc. Therefore, this is by and large the kind of apprehension, the kind of fear, what I noted and what I have been approached in terms of what can be done. In my opinion, the best possible thing is in tune with three important aspects. The people, the personnel, the doctors, and the other healthcare workers must be aware about the nature of the guidelines to be complied with. Number two, the nature of precautions must be followed in its strict adherence. Number three, the significant one, the people who are must be trained in terms of these aspects. If this care and caution is observed, I think the possibility of a legal remedy gets minimized. That's what I mean. In the light of this, as I mentioned, considering the nature of the practice, particularly the profile of the doctors who are participating in this webinar, I've identified certain fact situations. These fact situations pertain to the doctor-patient relationship, the clinic/nursing home or hospital relationship, the underlying condition of the patient. In a situation like this, what alternatives can be thought about? That is how a sizable number of fact situations we have. Each one I'm going to raise and explain to you. That is how the presentation is going to continue. Now, to begin with, when should a patient has to consult a gynecologist in person? Please remember, almost all these situations, they emanate from a particular factual apprehension or fear. That is, whether there is a possibility that the patient may get infected. Therefore, there are certain hotspots where it is better to avoid. One such a thing is hospital or nursing home or clinic. Now the question is, that does not mean a patient who is in need of a service cannot be taken to a hospital. No, that's not the situation. Therefore, this particular question assumes a lot of significance. In other words, face-to-face consultation with the gynecologist when a patient requires. As you know, there are different reasons, purposes, or problems a person may approach a gynecologist. A one-liner shall not or maybe cannot be the answer. Therefore, factually, one needs to really scrutinize the relevant factors vis-a-vis the patient. There are certain factors where the patient may have to approach gynecologist in person because of her own underlying condition. In such circumstances, whether it is the present context or otherwise, there is a need for the person to meet in person the gynecologist. Having said, there may be other situations where the need for in-person consultation may not be there. Therefore, there are three important situations. Number one, considering the underlying condition of the patient, the gynecologist has to take a decision whether there is a need for in-person consultation or not. Suppose there is no need for such kind of consultation, then what is the alternative then? And the third, the most important, whether such kind of consultation can be either postponed or deferred for a later date. I think these are the ways in which this particular fact situation need to be addressed. I think by and large, this is applicable to other specialties as well, particularly IVF. I think the first and foremost question to be asked is there a compelling need for the people to meet the IVF doctor in person? I think that is something that the reason why we are discussing is the potential the potential for spread and transmission is little large. Therefore, these steps. However, in the best interest of the patient, if there is a need in the light of a particular fact, underlying reason, I don't think there is any problem. The person may be advised to meet the doctor concerned in person. This is about one such situation. Second, in case if the patient is suspected to have COVID-19 symptoms, when such patient should consult a gynecologist in person? I think this is a very, very, very crucial aspect. In fact, the COVID guidelines make it very, very clear that whoever approaching the premises, hospital or nursing home clinic, must be subjected to thermal check. And accordingly, in some big hospitals, very detailed screening that takes place. In that way, we need to really look into whether a person who says that there is a possibility I'm having this kind of symptoms or possible exposure, etc. Naturally, gynecologist or the doctor concerned must take a decision whether such person or the patient should meet her in person or him in person, or should approach some other hospital where the designated service is rendered. It is only because there are two important reasons. Number one, mild to moderate and asymptomatic. In both the cases, it is necessary that a kind of situation where the person testing properly. Therefore, to that effect, depending upon the reasons, the social reasons, it is not necessary whether the person should meet the gynecologist or IVF specialist. I think the person may have to approach some other hospital and the doctor. I think to that effect, the doctor's advice must be very, very careful and cautious in advising the patient whom to meet, which hospital, etc. Say, for instance, a particular woman wants pregnancy, but she wants to know, should she wait because of COVID-19? And she approaches gynecologist. May not be in person. Now, the question is, how do we handle this kind of issues? On one hand, the medical information with regard to transmission of virus is evolving even today. Having said, there is reliable source of information, credible information indicating that a particular person of a nature may not be. For example, fetus in the pregnant mother, or baby in the womb of the mother, etc., etc., and mother to the child, etc. It's very clear there may not be a transmission. But having said, in terms whether to carry pregnancy during this season, I mean during this context or not, I think it is a kind of general medical advice that is to be provided. There is no mandate or prohibition saying during COVID nobody should become a pregnant. There is no such guideline at all. Therefore, a proper medical advice, however, linking it to the discretion, autonomous decision of the person or the patient must be given, and let the individual woman take a decision whether to postpone or whether to carry whatever. But to this effect, it is necessary the gynecologist or the doctor concerned must possess the current and updated medical information about the virus spread and transmission. I think in the light of that, there is. Will it become a legal risk? I mean, for example, we do not know as matters stand. But subsequent to pregnancy, at the time of delivery, some other factor, etc., if the child gets infected, naturally there is a question. No doubt that it may not be related to the issue of carrying the pregnancy. It may not be. But still, there is a possibility the woman may think and construe that had you advised me the other way around, I would not have continued with the pregnancy, or I would not have selected for pregnancy. I think these are the reasons why a properly informed medical advice must be given with a very insignificant discretion or autonomous decision, leaving to the woman to decide whether to have it or not. Whether OBG practitioner can be asked to serve beyond his or her clinical competence. In fact, this particular question, before firming up, I was thinking, should we have this medical fact situation or not? I realized even in our context, and more particularly some of the jurisdictions where the surge of numbers is so unpredictable, there may be a situation for a gynecologist who may be asked or ordered to do whatever the service in the overall interest of their patients. I agree that a private practitioner may not have that kind of situation to face. But whereas in a government hospital, there is every possibility, irrespective of the kind of situation, or a person with the concerned speciality of the doctor, the person may have such kind of thing. In such a case, whether a practitioner can be asked to serve beyond his or her clinical competence. When I looked into the global experience, what I felt was the overall community interest, that's what matters. Having said, please remember, what is that precisely the registered medical practitioner has been asked to do is something to be scrutinized from very, very close quarters. If it is to do something with an ordinary or MBBS doctor, whatever he, etc., then in such a case, considering the community interest, it may not have any kind of legal implication. But suppose a doctor was asked to do something which is not of a registered medical practitioner, but much beyond her qualification and experience and specialty, then what is to do? Then there are doctors, associations, and councils. They gave advice stating that the OBG practitioner or such medical practitioner cannot be asked to do such a kind of thing. Therefore, the response to this kind of fact situation lies in what is that specific nature of service which he or she was asked to do. I think in the light of that, it requires to be responded to. This is something I personally got several queries from different doctors and hospitals. The query is as follows. Some patients are demanding extra repeat prescriptions as they want to stock it. How to handle these patients? In fact, when I got to know that kind of thing is happening, I asked whether medical shops are under closure. According to lockdown guidelines, they come under essential service, they are open. Maybe from a particular stipulated duration or period of time. Then where is the need? Then doctors and hospitals, they said, no, the stock may not be because supply chain may be in difficulty. As a result, some of the patients, they are very, very keen to have this kind of thing. Now, from a patient point of view or a patient attendee's point of view, there may be a reason, a bona fide reason for them to adopt or indulge in such practice. But to my mind, depending on, even though the context demands so, it is not advisable, desirable to give such repeat prescriptions unless, please remember, unless there is a legitimate reason for doing so in the light of the underlying condition of the patient. If not, in my opinion, it cannot be justified either legally or ethically. Therefore, patients may continue to demand. I think we need to counsel them, we need to communicate, saying that in their own interest, that is not what is expected. But having said, there may be certain situations like life-threatening or some other situations, very serious, chronic, incurable, etc. Considering the underlying condition of the patient, I think the doctor may exercise his or her clinical decision and accordingly offer to some kind of reprieve to such kind. Therefore, the response is twofold. A blanket repeat prescription is strictly no. However, considering the underlying condition, if there is any possibility, etc., if there is a need, I think the doctor, his or her own clinical decision, may give that kind of thing to possible extent. Now, what is to be done when an employee informs that he or she has symptoms? Frontline workers will go. Please remember, the moment there is an information, the person must be isolated. The person must be subjected to the test. Depending upon the finding, mild to moderate, quarantine, etc. It is only because that is the standard of care that requires to be adopted as mentioned by the guidelines. If such a person, despite the symptoms, continue to discharge functions, that's a very, very potential legal risk for the institute, hospital, or the doctor's concern. It is only because the possible transmission cannot be ruled out at any stage, at any cost. Therefore, the moment there is such information, what needs to be done as per the protocol is to be done very, very clearly, and there is no exception at all. Next, what do we do when we get to know that a particular employee has been exposed to COVID-19? There is a possibility that a person may have symptoms. A person means your own person. Could be a doctor or nurse or any other healthcare. But there may be a situation, the person may not have symptoms, but the person got exposed to a particular patient, confirmed patient of COVID-19. Even then, the guidelines make it very, very clear that the person must be subjected to the process, protocol, and must not be allowed to render service. It is only because exposure to COVID-19 patient, in almost every case, the nature of the symptom, the degree of suffering may not be serious, but definitely mild to moderate. In such circumstances, even then, the protocol, and if at all there is information, and despite that the hospital or nursing home doesn't act upon, a potential legal risk to be faced in future. It is only because if the process of tracing reveals that such and such a person, despite the fact that he or she is exposed, has not been isolated and allowed to continue to discharge duties, and that is how got in touch with the various patients, etc. It is a very, very potential legal risk. Now, the moment we say our employees, colleagues, etc., related question is, are we bound by confidentiality obligation with regard to employed COVID-19 related information? I think there are a couple of things. Confidentiality, of course, it is applicable as a matter of legal mandate and as a matter of ethical mandate. However, whenever there is a duty to disclose to the concerned statutory authority or governmental authority, the disclosure must be made. To that effect, the disclosure of information does not amount to breach of confidentiality. But otherwise, the information about a particular healthcare worker or nurse or doctor must be kept confidential insofar as the institution is concerned. Failure to do so, please do take note, a potential legal risk. This is another question many of my friends have asked repeatedly, speaking in the context of Bangalore. Suppose there are legitimate fears of exposure. Can we still require employees to This is where the two important factors which you need to keep in mind. On one hand, whether the service that is required to be done to the patient, is it legitimately required at this point of time? Emergency situation, elective situation, etc. Particularly gynae. It is but natural if the woman undergoes a particular complication, delivery, so many factors. In such a case, naturally, the hospital requires different types of employees to do the work, to render the service. Therefore, there is a fear of exposure, but still there may be a need for, when once such a need which is identified as a legitimate, then there is a very reason for such kind of thing. And despite such kind of fear of exposure, you may. Then the second part, please remember, under no circumstances, in fact, when we watch news and a lot of our very popular WhatsApp university, I would call, lot of messages, necessary, unnecessary, doesn't matter. Everybody forwards the message, whatever he or she receives. When we read, we understand, we do not know whether it is factually true or not. I mean, barring mainstream TV, etc., where doctors or frontline workers have not been given the protective gears, protective kits. How do you expect when you know that there is a legitimate fear of exposure? I think that's what I am saying. Please remember, if the service to be done, you consider it as legitimate, naturally, you need to look into whether the participation of such person, then in such circumstance, what are the precautionary measures? What are the protective things? All the things must be provided. Please remember, if at all there is a failure on the part of the employer or the hospital in providing so, it is indeed going to be a very, very significant legal risk. Therefore, on one hand, legitimacy, on the other hand, requesting or requisitioning service, on the other hand, the precautionary measures, because there is a duty on the part of the employer to protecting the lives of people who are rendering service in this crisis situations. This is another important thing which many of our friends and colleagues ask. Is there a legal risk if an employee gets infected during the discharge of functions? I only hope that you have had the opportunity to read at least the pertinent guidelines which you are subjected to. In one of the guidelines, Ministry of Home Affairs made an observation about, in case if the employee or worker or any other inmate or personnel gets infected, the employer may be subjected to whatever the accountability is. Strictly speaking, we need to look into whether legally that is possible or not. That is one aspect. Because of such a kind of notification, most important thing is, in case if the employee gets infected, can that become legal risk? In my opinion, yes, it can become a legal risk. However, please remember, however, what are all expected by you as an employer, as a colleague, as a doctor, will be scrutinized, pinpointed. If there is a compliance, despite that there is, then there is a very possibility. Otherwise, if at all there is any kind of deficiency, which clearly, glaringly indicates, but for the exposure on account of deficiency, the person would not have been infected. If that is the kind of thing, I think it's going to be a very, very important legal risk. Therefore, it is necessary and important and mandate that precautionary measures are followed very, very clearly and carefully. This is another. I hope you must have heard about the recent Supreme Court judgment 2018, where they have mentioned about advanced directives. Some of the European and American states and jurisdictions, this issue has assumed a lot of significance. Let me put it in a perspective. Advanced directive means something like a living will or DNR, DNI, do not resuscitate, do not intubate, this kind of directives where the patient in a particular condition of consciousness and capacity, rights, and accordingly, in case if the patient or the person uh, lands up or faces or encounters such a situation, the doctors will, they respect those in the country. Now, in India also, legally they have been recognized. Now, the point is, in COVID-related situation, are they applicable? One of my very senior doctor from Delhi asked me this question. I said, of course they are. But the process with regard to when and under what circumstances such a directive can be made and when such directive can be put in practice, I think these are the two significant issues. And accordingly, the doctor's team, with regard to the family attendants, etc., they take a collective decision. To put it in simple words, whether advanced directives apply to the context of COVID, yes. In fact, I was preparing for this particular session. I was reading various experiences in different jurisdictions. I have come across one in, I think, Italy and another one in America, state of Ohio. A 30-year-old man infected with COVID-19, and between parents they had different opinions, etc. When he was conscious, he wanted to have a particular directive, etc., etc. But because of difference of opinion between father and mother, they could not take a decision. And unfortunately, the young man passed away. That shows how advanced directive in a given situation, if a person who is not capable, not conscious, cannot take such a, the person when he was in such a situation, in the event, for example, there is a possibility, the COVID symptoms tested positive, there is a big possibility of the kind of seriousness, etc. At that point of time, some kind of directive, maybe DNR or DNI, etc. But unfortunately, he could not, because their father said no, mother said you may have to think, but in between he died, and that is how. I was reading another European, an elderly man got infected with COVID, and it so happened doctor inquired, was there any advanced directive? Then I think son or grandson, someone said, no, there is no such. Then they said it is very, very chronic. Hospitalization is not necessary. Any moment the possible death may take place, and accordingly palliative care has been taken. Palliative care continued, and it so happened he recovered from corona, and he is leading a healthy life. I think these are the two contrasting situations where very clearly indicate whether the advanced directives do they apply to COVID-19. Of course they are. Now, for instance, those who are availing or proposing to avail IVF, is there any alternative to them instead of face-to-face consultation? In my opinion, unless a situation or a process or an intervention where the physical presence of the woman or man, whoever it is legitimately required, in my opinion, or for any other diagnostic processes, etc. In my opinion, the consultation can be through any other medium. That is the reason why many jurisdictions For most parts of this particular IVF, as I mentioned, but for intervention process, diagnostics, etc., the consultation goes through the most notable process, that is telemedicine. I think that's where we need to identify. The same thing is applicable to a gynecologist as well. For example, in a situation where the patient doesn't experience any complications or there is no urgency, considering the underlying condition, and there may not be a reason for either deferring or postponing consultation. In such a case, a telemedical practice, I think, is the most, and I'm sure every one of you are aware, Board of Governors. We don't have Medical Council of India. Board of Governors, in supersession of the Medical Council, passed a notification pertaining to telemedicine practice. For your information, 23rd March 2020 and 25th March 2020, Ministry of Health and Family Welfare, they have issued the notification saying that these guidelines have come into effect. And accordingly, please remember, in the present day context, in my opinion, one such a platform, which is in the best interest of everyone, possibility of spread of infection is nil. I think that may be invoked. And I think to that effect, at the right time, both Board of Governors and Government of India acted. I'm sure you are aware, in this country, I think 2019 later part or something, some of the state medical councils, they gave a legal opinion stating that telemedical practice, etc., is not to be, because that is not accepted or endorsed to be the Code of Medical Ethics, etc. I mean, it is their opinion and we respect that. But having said, we always felt that with the changing times and the technological advancements, telemedical practice can be put to use, catering to the needs of millions of people. It so happened, COVID context made it that possible. And accordingly, this notification has been passed. Now, the question to this effect is, if this is the most viable option, etc., who can practice? According to the notification, any registered medical practice can, no problem. You may have Karnataka State Medical Council registration, still you can guide, advise, and consult any patient from any other state as well. Therefore, registered medical practitioner, please. And in addition, it mentions about certain compliance factors. And accordingly, the following complaints. Number one, telemedicine should be appropriate and sufficient. I mean, this is something I personally feel it is very good that the notification makes it very clear. Whether to treat the patient in person, I mean, consult, whether to provide consultative advice in person or through telemedical practice, I think the doctor must take the final call. And accordingly, considering the context and underlying condition where she has to, and identification of the registered medical practitioner and the patient. Please remember, this is something very, very crucial, so that the name, the qualification, the experience, the place where he or she is working, and the photo identity, etc. Similarly, the patient. There is a very possibility in the guise of a patient, some other person may, therefore, and accordingly the mode, it could be a video consultation, it could be audio consultation, it could be a telephone consultation, etc. Please remember, you require patient consent, and accordingly the patient consent, so that the patient reasonably informed about the ways in which the telemedicine advice or consultation is, and in a limited, please remember, in a limited way, even prescription of drugs can take place, only particular scheduled goods, etc., OTC, and no other scheduled goods. And in that way, telemedical practice, in my opinion, in the present COVID context, both for IVF and the gynecologist, to a maximum extent, it can be of great help. The concluding question, what I want to pose is, though it is not strictly medico-legal, but it is related to medical practice. The situation is as follows. Because of lockdown, OBG practitioner could not open a clinic or nursing home for more than 3 months. The question is she entitled to claim waiver as to rental payment? In fact, when the lockdown took place, the one legal issue which has been discussed pan-India, different groups, etc., is about this aspect. Because when the operations have been shut down, when there is no generation of revenue, but as per the lease deal or rental agreement, the rent needs to be paid. Therefore, whether there can be a waiver, I think this is where the most important legal issue, which is normally looked into, is the force majeure. Force majeure means it is something like a unexpected event, literal language, and accordingly depends upon how the clause is structured, etc. Therefore, by looking into the lease deal, one can be able to really look into in what way the force majeure clause has been drafted, whether there is a possibility. In my opinion, there is indeed a definite possibility to claim waiver of such a. Okay, I think with this I conclude. If any questions, etc., you are most welcome now.
Sir, thank you for a great session. So there are a few questions. The first question is, in spite of all precautions taken, safety measures, training of all the staff, if the IVF patient turns positive for both COVID and pregnancy, which is a scenario of great dilemma, can the couple sue us for this as a negligent action?
I request you to repeat the last part of the question. Hello?
In spite of all the precautions taken, safety measures, training of all the staffs, if the IVF patient turns positive for COVID infection, as well as she becomes pregnant during the treatment course, which is a scenario of great dilemma, can the couple sue us for the negligent act of couple, like the wife being positive for the COVID infection?
Yeah. Now, the question is, before I answer that question, I wanted to ask you, the possible transmission of that infection insofar as the mother is concerned, is that attributable to any deficiency on the part of the hospital? Hello?
All the precautions were taken and safety measures were taken and all the staffs were trained.
Okay, despite those measures, if she gets, in my opinion, if the measures have been taken and accordingly still she gets infected, there cannot be a case for negligence or deficiency of service. However, please remember, strict scrutiny will be made as to whether you have complied in its letter and spirit or not. Am I clear?
Yes, sir.
Okay.
And the second question is, if our employees turns COVID positive in spite of all safety measures given to them, is management liable?
This is where I told you in the light of the notification. A notification is silent about that. That is the reason why I said we need to test it legally. As per the applicable legal principles, a particular adverse consequence may ensue despite taking precautionary measures. If so, the person or the institution cannot be made accountable for negligence or deficiency. But the notification does not say so. What notification says, no, if the employee gets infected, it is the employer who has to subject it to whatever. In my opinion, that may not be correct. That's what I think.
So, and the next question is, can we give fit to fly certificate to pregnant patient? Do we need to do a COVID testing before that?
You mean before flying?
Yes, sir. Before issuing the certificate to fly.
Very honestly, I'm not very sure about the Ministry of Civil Aviation regulations. I don't think there is such a mandated duty. However, regular process of thermal check will be subjected. I mean, the woman will be subjected. But I don't think there is any duty that before flying, one has to get a COVID-19 report. No.
And the next question is,
Yeah.
if the patient travel history and exposure to the COVID patient, or he has not completed the quarantine, comes and seeks the treatment in the hospital. Meanwhile, after testing, he or she turns out positive for the COVID-19, and we have to shut down our hospital and we suffer the financial loss. Can we seek legal action against that patient for the negligence?
First thing, why did you treat the patient?
They did not tell the travel.
They didn't tell the travel history. They didn't give any other high risk histories.
In such a case, yes, legal action can be initiated against the person.
Okay, sir. And one more question. If a couple or a patient seeks advice through teleconsultation after prescribing medication, if the disease is not cured or it increases, can the patient take a legal action against the doctor?
No, unless while prescribing the drug or whatever the nature of the composition, etc., there is a deficiency. If there is nothing, there is no negligence or deficiency to that effect, case cannot be filed, because relief may not be there, or there may be escalation as to the condition. That does not mean it is because of negligence of the doctor. No.
Thank you so much, sir, for providing your valuable time for this webinar in your busy schedule.
Thank you.
Yeah.
And I want to say thanks to Dr. Asha for giving me this opportunity.
Thank you, sir.
Thank you, sir. You have enlightened us on the medical legal aspects and the guidelines during this COVID-19 pandemic very well. And you have stressed on the need for the content-specific informed consent has been explained in detail. You have nicely explained us how to manage patient and counsel regarding further treatment. You have clearly explained the role of teleconsultation, which has helped us to modify our practice. Thank you so much, sir.
Thank you. Thank you.
Now I
A warm and happy afternoon to all the participants, our honorable speakers, GGIR HR management, support staff, and everyone else gathered here. It is my privilege to propose a vote of thanks and acknowledge the contribution of those who worked hard to make this CME so successful. I am Ulfat Khan, and I am the operations manager of GGIR HR, a premier training organization in the field of reproductive health and infertility. On behalf of all of us, I extend my most sincere thanks to the Almighty God for making today's event a resounding success. I take utmost pleasure in thanking all the participating doctors for having taken time from their busy schedules on a Sunday. Your eagerness to learn is very motivating and encouraging. Thank you, dear participating doctors, for being such a wonderful audience today. Next, on behalf of Team GGIR HR, I want to thank our key speaker, Dr. Sonal Panchal, for sharing her immense knowledge in such a lucid. I take this opportunity to thank our other key speakers, Dr. Sripada Jogarao and Dr. Asha S. Vijay, who spared time from their busiest schedules to grace the occasion and share their experience, knowledge, and expertise with all of us. I am immensely thankful to Dr. Maheshwari for her smooth and flawless anchoring today. An event like this cannot happen overnight. The wheels started rolling few weeks ago. It requires planning and a master's eye to plan and execute. A special mention to all the staff and management team for their tireless work. We have been fortunate enough to be backed by Intas Pharmaceuticals. A special note of appreciation to their whole team and its management. Thank you all.
Now, Dr. Maheshwari will be announcing the 2 lucky winners for asking the best questions today. Over to you, Doctor.
Thank you, Mrs. Ulfat Khan. The 2 lucky winners today are Dr. Ragini and Dr. Vishnuvardhana. Dear winners, a coordinator from our GGIRHR team will contact you shortly to share the details of the prize. Thank you all for attending the CME and making it a huge success. Stay safe and have a wonderful day.